Hello, good
Hi,
evening.
very good evening.
Yes, so welcome to yet another exciting sixth edition of this Shake Heart Symposium on saving deaths and damages from heart attacks. And we are glad to have a very highly esteemed faculty with us. And we are starting with the first session now. And I will just uh, welcome the moderators for this session. Uh, I have Dr. P.K. Gupta, Dr. Sachin Upadhyay, Dr. Peter Kala, who is also a speaker, and we also have Dr. Anil Kumar as a speaker here, as well as he will also help and participate and contribute in moderation. Now, this year, the conference is a hybrid for everybody's interest. So today's proceedings are only virtual, and tomorrow on Sunday, it will be hybrid. So we'll have an in-person meeting as well. So it has been a harder task. I realized that if you put individually X amount of effort in doing only live, or if you put X amount of doing in physical, then actually you end up putting 4X amount of labor in making it hybrid. It is much more challenging to create a platform and do both the things together. But we are into it. We are doing this, and maybe next year onwards, it will be trying to do hybrid all the time. Although we are missing the presence of our and personal meetings of Dr. Peter Kala and Dr. P.K. Gupta. So it's always always a pleasure to meet in person. So hopefully next year, it will be hybrid, but hopefully we'll be able to see you in person. So without delaying much further, we go forward and we start the scientific program. And I hand over the podium and dais to the esteemed moderators. So welcome.
All right, then a very good evening to all of you, and of course, good afternoon in UAE. And I would like to extend a very warm welcome to each and every one of you who has joined this wonderful meeting organized by Dr. Brajesh Mittal every year. And I'm very proud to be associated since inception as Dr. Kala. So we are just kicking off the first session, and we have got a very renowned international as well as national faculty. And to kick off the first session, the first lecture we have got challenges and unmet needs in STEMI. And that's a burning problem we all face in our day-to-day clinical practice, whether interventional cardiologists as well as non-interventional cardiologists, depending upon where you are practicing. And to address this issue, we have got a very renowned speaker, Professor Peter Kala, who is the head of Department of Internal Medicine and Cardiology, University Hospital, Czech Republic. And we are all familiar with him. So, Professor Kala, it's all to you.
Thank you very much, and we can go ahead. So thank you very much again for invitation.
Hello, dear ladies and gentlemen. It's my great pleasure to be with you from my country, from the Czech Republic. And I would like to thank the organizers of the SHAKEHEART meeting this year for inviting me. My topic for today is called Challenges and Unmet Needs in ST elevation myocardial infarction. These are my disclosures. And if you are talking about the unmet needs or challenges, from my point of view, there are still some, especially in complex clinical and anatomic scenarios. What I will mention today will be the management of large thrombus burden, that I see as a quite important topic, cardiogenic shock and mechanical circulatory support, and out-of-hospital cardiac arrest. And after that, complete revascularization in multivessel ST elevation myocardial infarction, except for cardiogenic shock patients. I won't touch the rest of potentially important issues that are mentioned here. If I'm talking about the large thrombus burden, so we know very well that this is really something that makes the outcome of the patient worse. And you can see unfavorable incidence of no reflow phenomenon, where the thrombus grade plays an important role, and per grade increase, it's 1.8 times higher risk of no reflow phenomenon that may be interpreted also in worse outcome. The large thrombus burden, we can think about deferred stenting in this particular situation, because we know very well that after stenting, if there is a really large thrombus, so there is a risk of reocclusion, maybe some increased slow flow, no reflow, increased stent thrombosis, and late stent malapposition. We also use smaller stent sizes due to vasospasm. And there may be some advantages: low thrombus burden, lowering thrombus burden, decreased periprocedural MI, improved thrombolysis in MI flow, slow flow, no reflow prevented, larger stent size, and lesser number of stents implantation. And also, it should be smaller infarct size. We have a couple of trials that dealt with this issue, but with a relatively clear message that deferred stenting for routine practice is not recommended. But if we are dealing with large thrombus burden, it can maybe different. We have the data from about the thrombus aspiration, a manual thrombus aspiration. Very promising data represented in 2008 from the TAPAS trial. You can see the conventional PCI, the green line, and thrombus aspiration with very promising results. But after that, it was not confirmed by larger trials. It was paced 5 years later, and there were no significant differences between the conventional PCI versus PCI plus thrombus aspiration. On the opposite, we have the total trial results that show on more than 10,000 patients, the largest trial available, that showed that there is no clinical benefit of routine thrombus aspiration. You can see the cardiovascular death, myocardial infarction, shock, or class 4 heart failure, stent thrombosis, target vessel revascularization, no significant difference. And on the contrary, there was a high risk of stroke, unfortunately. And you can see that the time to stroke is not really associated with the thrombus aspiration itself, though there were some cases also connected with this complication. But you can see that thrombectomy versus PCI alone were significantly worse in terms of the stroke rate. And these are the high thrombus burden, sub-analysis, and outcomes at 30 days. What we know is that the high thrombus burden really worsens the outcome, clinical outcome, and you can see the cardiovascular death here. High thrombus burden in blue and low thrombus burden in orange. And so it's very clear that we should deal somehow the large thrombus burden. Optimally, some specific techniques, maybe some specific approaches. If you are talking about the high and low thrombus burden, so the blue columns means the high thrombus burden, and you can see that it has an impact on cardiovascular death, significant impact, cardiogenic shock, heart failure, and stroke. So quite important issue. Regarding the cardiogenic shock, we have very nice SKY shock classification from A, at risk, to the worst situation, that means extremis, E, that means patient with circulatory collapse, frequently in refractory cardiac arrest with ongoing CPR, or are being supported by multiple simultaneous acute interventions, including ECMO-facilitated CPR. And what we know now that from C, D, E, we can think about the use of ECMO, extracorporeal membranous oxygenation, that can be delivered by the interventionalist truly percutaneously. And we have the classification and shock phenotyping. And we very well know that if we deal with patients with really deep cardiogenic shock, the prognosis is quite bad. You can see it here. This is SKY-E type shock. And you can see the 30-day in-hospital or 30-day mortality. That means short-term mortality up to 80%. And if we combine this situation together with out-of-hospital cardiac arrest, it's above 80%. On the contrary, if we have the patient at risk, so the prognosis is not so bad. So we have to be very cautious in this population, and we should educate the population that they should call the emergency as soon as possible. About the antithrombotics in cardiogenic shock, there is maybe some promising data coming from IABP Shock 2 trial about cangrelor. And these were cangrelor in cardiogenic shock and after cardiopulmonary resuscitation. And from 143 consecutive patients treated with cangrelor, 88 were selected for as a match for the control group. And cangrelor-treated patients in cardiogenic shock in this multicenter observational study experienced similar rates of bleeding, improved kidney flow, and numerically higher survival compared with matched controls treated with oral P2Y12 inhibitors. At the same time, now we are working on the shock AMI trial and the PRAG-23, and we are waiting for the results because this is clear, and this should be a clear answer for this issue. What about the invasive hemodynamics or proper hemodynamic monitoring in patients with cardiogenic shock? And you can see on the left side, if there is none or incomplete assessment or complete assessment, it may have an impact on the patient's outcome. You can see it here, SKY stage E, and the impact of complete assessment, including relatively aggressive invasive hemodynamics. So it may have a positive impact on the outcome. You can see the stage D, there is as well a positive impact. What about the devices? We have the ECMO, I mentioned it already before, and we can use also the impeller in cardiogenic shock. And you can see probability of any death in veno-arterial ECMO in the red line compared to combination of ECMO and impeller. That means left ventricle unloading, and you can see that the results are significantly better if we combine such these two devices. And it's true for any cohort of patients, including the elderly, younger population, etc. At the same time, we have to have experienced teams because the shock teams improve survival. And it's very clearly, has been clearly demonstrated that the shock team has to be placed, and it has to be a combination of physicians working in critical care, advanced heart failure, interventional cardiologists, cardiac surgeons, and ECMO service. And this combination can make a really fast therapeutic intervention selection. And what about the risk of death and hospitalization after discharge? Because if the patient with cardiogenic shock survives, it's not the end of our care, of course. And you can see very clearly that the 2 months after discharge are really critical for the patient, and we have to be very much focused on our approach and our care of this population. You can see what is it if the patient doesn't have cardiogenic shock, and the blue dotted line if they have cardiogenic shock. And it may be death or all-cause hospitalization within 2 months. After that, the prognosis is much better, as you can see on the right side of the panel. Out of hospital cardiac arrest, and this is quite important topic. We have 10 parameters that may define how risky is the individual patient. But at the same time, from these 10 parameters, we have to select 3 or 6 that are even more significant. That's quite important topic, and we have more and more patients that are coming to the hospital by the emergency, by the ambulance, and we have to deal with them. What about the multiple systemic, PCI versus medical therapy? We have quite a lot of trials, and I would like to mention compare acute, and after that, of course, the original one from a culprit dynamic. This is the culprit, compare acute, complete versus culprit, only PCI, functional revascularization. And you can see that the complete revascularization is associated with better outcome in terms of MACE. But it's about revascularization rate. It's not about the hard endpoints. So in these hard endpoints, it's similar, but we are talking about the index hospitalization. And during index hospitalization, so complete revascularization is possible. That's quite good. It's safe, but it can be done also after the hospitalization till 30 days. And we have the largest trial that is complete trial, and here's the core primary outcome, cardiovascular death or a new MI, clearly demonstrating that complete revascularization is better. And it's in combination with ischemia-driven revascularization, and the difference is even higher. So, to conclude, ladies and gentlemen, completeness of revascularization and no cardiogenic shock multiple systemic remaining questions, optimal timing, anatomic versus functional complete revascularization, does the concept of complete revascularization fit for all, including very elderly, frail patients, patients with chronic kidney disease. And what we know currently is that for the cardiogenic shock patients, the complete revascularization is not recommended on routine practice. These data are coming from culprit shock trial. So there are still some challenges and unmet needs in STEMI, ladies and gentlemen. And I would like to conclude that management of thrombus burden, we have to use individual approach. Do not hurry. In patients with cardiogenic shock and mechanical circulatory support out of hospital cardiac arrest, this is complex issue for shock and OHCA teams. Promising concepts of mechanical cardiovascular support, unloading and invasive monitoring. Optimal antithrombotic regimen should be assessed. Close clinical management has to be applied after discharge, and experienced collaborative teams are crucial. And about the complete revascularization multiple systemic, except for cardiogenic shock patients, there is a matter of timing in hospital or within 30 days, anatomic versus functional, and there are still some exceptions always that are always acceptable. So thank you very much for your intention and for having me.
Thanks, Dr. Kala, for excellent presentation on challenges and unmet needs in STEMI, and going through the thrombus burden, out of hospital cardiac arrest, and need of assisted devices, including the ECMO, arterial ECMO, and Impella, and then subsequently culprit versus complete revascularization. And I would request all the audiences to write their questions, and we will take all the questions at the end of session, and it would be pleasure of all the speakers to answer all your questions. Thank you again, Dr. Kala, and now I would request Dr. Sachin to introduce the next speaker.
Yeah, thank you, Dr. Gupta and Dr. Peter Kala. It was indeed a very nice presentation. Thank you very much. And moving on from the relevant topics of cardiogenic shock and ECMO and the unmet needs of STEMI, as you elucidated in the talk very nicely. We as a cardiologist are always in dilemma when it comes to ischemic thrombotic versus bleeding risk. We have to optimize our management, individualize our management to the patient's need. And to deal with such situation, Dr. Anil Kumar is going to enlighten us with his talk, Art of Antithrombotics, High Bleeding Risk PCI. Dr. Anil Kumar is Head of Cardiology in Aster Medicity, Cochin. He needs no introduction. He was a very eminent cardiologist in UAE before he moved to India, and is doing a wonderful job in academics as well as clinical part. So I request Dr. Anil Kumar to please start his talk. Thank you.
Good evening. My talk today is high bleeding risk angioplasties, strategies and management. First of all, I thank Dr. Mittal for asking me to give this talk in the SHAKEHEART conference of 2022. Let us look at high bleeding risk angioplasties. These are basically complex high risk indicated procedures. And you can have high risk, moderate risk, or low risk. When you look at the high bleeding risk angioplasties, these are increasingly common in our day-to-day scenario in the cath lab, with more and more patients requiring angioplasty being in the high bleeding risk group. And when risk factors for bleeding are there, the risk of angioplasty and the post-angioplasty care is also totally different. So we need to look at why we need to manage these high bleeding risk patients differently. The optimal management has not been elucidated in many of the clinical trials, as most of these high bleeding risk patients are excluded from these trials. And so people ended up using bare metal stents. Now, in most of our areas, bare metal stents are no longer available. And most of the European guidelines, at least, have switched to drug-eluting stents to be the choice of stent in the high bleeding risk group. If you look at the incidence of bleeding, it's most commonly from the gastrointestinal tract and most commonly occurs in the first 30 days. And when you're just started on a dual antiplatelet after angioplasty, be it low risk or high risk, any bleeding, particularly major bleeding, carries a poor prognosis. The impact of bleeding is that there is increased mortality. It also increases the incidence of stent thrombosis. And obviously, you know, stent thrombosis can have as high a mortality as 45%. Why does stent thrombosis happen after bleeding? There is formation of more immature, larger, denser, and more reactive platelets. So you have to realize that there can be more thrombosis also when bleeding occurs, though it sounds paradoxical. So now let us see what is the definition of a high bleeding risk patient. The Academic Research Consortium has proposed a definition for patients undergoing angioplasty. And this includes major and minor criteria. And this includes what is called a BARC criteria, which we will be going into it more detail in the next slide. The BARC criteria 3 or 5, which has a 4% incidence of an intracranial hemorrhage, or a minor criteria where it has a less than 4% incidence of bleeding. So what is this BARC criteria? Bleeding Academic Research Consortium has classified into 0, 1, 2, 3, 4, 5. Now 0 is no bleeding and 5 is the fatal bleed. What is 3 and 4? 3 is when there is a hemoglobin drop of 3 to 5 grams, but less than 5 grams. 3A, 3B is more than 5 grams, and 3C is when it's intracranial hemorrhage or intraocular hemorrhage, which is the most dangerous type. Type 4 is the CABG related bleeding. So if you know 3, 4, 5, these are the most important classes of bleeding that occurs post-angioplasty. 2 is when it's not overtly actionable bleeding. There has been a bleeding, requires an evaluation, but does not require any further intervention. And having some bleeding that is not actually actionable, doesn't reach the hospital, that is type 1. So 0, no bleeding, 1 and 2, minor, 3, 4, major, and 5 is fatal, in fact. So we have to try and classify bleedings according to this BARC classification so that all of us are on the same page. When I say type 3 bleeding, you understand what is type 3 bleeding, and type 5 is fatal bleeding. So the ARC-HBR consensus definition has defined into major criteria or minor criteria, which would increase the risk of bleeding. And they have classified it in a table. But for your convenience, I put it more graphically in the next couple of slides. So you can see which are the risk factors which increase the risk of bleeding and causes the patient to have more of BARC 3, 4, 5 bleed. So this includes age more than 75, kidney disease, liver disease, active cancer, anemia, very low platelet count. These are all self-explanatory as to why bleeding will be more. A recent stroke, intracerebral bleed, a bleeding diathesis, requirement of a transfusion in the past, use of oral anticoagulation, NSAIDs, or a planned surgery, anything which is to be recently planned, all these things increase the bleeding in the patient undergoing angioplasty. Now, again, to make it clearer, I've shown major and minor. The minor is in the light blue and the major is in the dark blue. So renal disease, when the EGFR is less than 30, pushes this into a major criteria. Liver disease, cirrhosis with portal hypertension, an active cancer within the past 12 months or an undergoing active treatment. A hemoglobin less than 11 puts the patient into the major criteria, and a low platelet less than 100. And stroke within the last 12 months would be a major criteria. A chronic bleeding diathesis or a spontaneous bleeding or the requirement for a long-term oral anticoagulant, that a patient with atrial fibrillation or a recent pulmonary embolism, all these are major criteria. NSAID chronic use is a minor criteria. So if you decide on this major and minor criteria, then you can classify the patient into the high-risk bleeding group and then plan your procedure accordingly. Of this, the most common subset that we are dealing, 20 to 30% of our patients have some sort of renal disease, and quite a few of them have end stage also. Moderate kidney disease is a minor criteria, and you have to realize that severe disease, there are many patients. In fact, I often keep pointing out to the nephrologist that the patients who die in the dialysis unit is most often of cardiac disease than renal disease, and 30% of patients undergoing are having CKD of the moderate intensity. So this group has come out with high bleeding criteria risk stratification app, and we have also used it. I will show you a couple of cases which we have used it. The ARC HDR, it's easily downloadable on your iPhone or the Android phones, and you could evaluate and find the risk. I'll show you an example as we go along. As a clinician, you have to balance the bleeding and the ischemic risk. We all know that the risk of stent thrombosis is highest within the first 30 days, whereas the risk of bleeding with a dual antiplatelet continues throughout the duration of dual antiplatelet. So you have to understand that the benefits of DAPT are the greatest during the first 30 days, and the risk of stent thrombosis continuously falls after that. This gives us ideas of a good clinical strategy to deal with. So if you have to develop a strategy for treating a high bleeding risk patient, you have to have an evaluation of the patient, complete evaluation of the patient, and then go ahead with consultation with other specialists as required. And then you plan and decide, is angioplasty the best option? Do the benefits of revascularization outweigh the risks of post-PCI bleeding? You really have to talk to your team, to your multidisciplinary teams, and are further investigations required prior to angioplasty? If after angioplasty suddenly you realize he has got a carcinoma cecum and needs a surgery immediately, is that the way to go ahead? You should identify these things beforehand before you do the angioplasty. Unless it's an acute STEMI situation, you always have time to think about this. Consider the access site. I don't need to tell you that the radial site is definitely far better than the femoral site, and prevention of femoral bleeding is of importance. Contrast load, especially in the renal patient, you need to look at the choice of the stent. We'll talk about it. Avoid complex interventions when possible, but try to complete the revascularization. That it's a CAT-22 situation. Avoid complex interventions when possible, but complete the revascularization. So when we look at the risk of clotting versus bleeding, you have to decide what is the stent design, what is the DAPT, what are the procedural variables, and what is the best practice evidence among the device and the drugs. And is it an acute coronary syndrome or is it a chronic stable angina? When you look at the healing process after a stent implantation, you understand there are different steps. There is albumin binding to the stent, platelet activation, inflammation, some smooth muscle cell proliferation with the drug-eluting stent tends to decrease, and then the reendothelialization. So you have to understand that the reendothelialization will be complete, and the faster the reendothelialization is complete, the decrease the risk of stent thrombosis. So if you have a stent which has complete endothelialization, you might need only shorter DAPT. But if there's a slow incomplete healing, because of the stent design, there's an increased stent of rethrombosis. So when you talk about the evolution of antiplatelet therapy, in 2006, it was still not clear, and people were still talking about putting a bare metal stent in the high bleeding risk era. But after that, things have changed. We have realized that there are new generation DES have shown an acceptable safety profile. And as of today, I think even in the high bleeding risk patient, you would be putting a drug-eluting stent, the latest generation of drug-eluting stent. So there have been a lot of trials of device and drugs, the DAPTs, and comparing the BARC type. I'm sure now you understand what is a BARC type 3 or a fatal type 5 bleeding, and we have enough data coming in. So we'll talk about the STOP DAPT study demonstrating the science safety with 3-month DAPT. And you have the STOP DAPT to ACS trial, where it shows that the 1-month DAPT and then continuing for the rest of the 11 months with clopidogrel is also safer. You have the Resolute Onyx DES trial for 1 month, and that has also shown safety. Even after 1 month of dual antiplatelet, the Resolute Onyx from the Medtronic platform and the POEM registry has also shown safety of the bioabsorbable synergy with 1 month dual antiplatelet. So there are enough data coming in. It's for us to evolve the strategy and DAP guidelines in 2017. You can see if trials which show that you continue aspirin with clopidogrel for 1 month. Outside to undergo left lower limb fasciotomy, but found to have troponin positive. He was in pulmonary edema. We started him on anticoagulation, and he underwent a debridement, but continued to have fever spikes. We just did an angiogram and found that he had an osteoproximal LAD and a mid-RCA 75% stenosis. Angioplasty was deferred in view of low platelet counts. We did not do in that sitting. We calculated the ARC HBR score and found that he had two major criteria: the hemoglobin less than 11 and the platelet was less than 100. He developed pulmonary edema again, even though the platelets dropped to 70,000 and bronchopneumonia was being treated, but he developed pulmonary edema. He shifted back to CICU, diagnosed with myelodysplastic syndrome and had multiple transfusions. Again, we assessed the risk versus benefit, and he was in the gray zone, and the risk of bleeding and MI was considered to be equivalent. So we found out that in the gray zone, we had a multidisciplinary team meeting and took him up for an angiography and angioplasty to LAD. You can see that the LAD is being stented. And after that, we did the stenting of the RCA with good results, got him back into the ICU. He continued to have fever. Unfortunately, he developed a fascia compartment syndrome of the radial hand. He had bleeding into the forearm, a very uncommon situation. But then we had the plastic surgeon come in and he was corrected and he had a good surgery, a surgical result for the fasciotomy. His hand improved and finally he improved in his echo and he had a left skin grafting. And this is the hand later on. And he has been walking around now. He's completed 8 months follow-up. Though he was readmitted with anemia, he had pneumonia. He's been changed to a single antiplatelet after 4 months. So just to conclude, it's a risk treatment paradox. Highest risk cases have the greatest incremental mortality. So you cannot back out from this high bleeding risk angioplasties. You have to explain to them that the stent thrombus is highest, but so don't stop DAPT in the first month. It is a choice of access, it's a choice of stents, choice of DAPT, and what more is needed? We need more data, whether single antiplatelet is efficacy, whether specific stent platforms have more benefits, whether drug-eluting balloons would be enough, and further trials of medical versus angioplasty we need to take in this high bleeding risk situations. So what is the take-home message? High bleeding risk angioplasties can have good clinical outcomes if utmost care is taken. You can use the available risk scores and plan the strategy. No HBR case is a set piece. You cannot always say, I will do this way. Each case has to be individualized. You have to individualize the DAPT therapy as required and involve the team members and use the multidisciplinary team approach. So if you take adequate care, you can get good results in high bleeding risk angioplasties. So that is the take-home message from my talk. I hope the message is loud and clear. Thank you once again for inviting me to this SHAKEHEART conference. Thank you.
Thank you, Dr. Anil, for that. Yeah. Thank you, Dr. Anil, for that wonderful talk. And you have covered a lot of the issues which are encountered whenever it comes to bleeding versus thrombotic risk. There are few questions, but as Dr. Mittal decided, we will discuss them at the end of the session. Because the one very common situation is PCI with atrial fibrillation and what should be the strategy. But I think we will discuss at the end of the session. And I will now request Dr. Mittal to take over and announce the subsequent agenda of the meeting.
Yes, thank you so much, Dr. Kala and Dr. Anil, so far. Excellent lectures, and I believe after listening to your lectures, if any such patient comes, I will refer to you respectively rather than burning my hands myself. These are really difficult situations and difficult scenarios. So we will proceed further, and there is slight change in the series of the lecture. So instead of Dr. Khanna's lecture, the next lecture will be from Dr. P.K. Gupta. He is on hypertension challenges. So Dr. Anil knows Dr. P.K. Gupta very well, and he can introduce and welcome and his topic also, which is hypertension challenges, everyday hypertension management, everyday needs. So Dr. Anil, over to you, please. You can welcome Dr. Gupta. Dr. Anil, are you there? Well, so I will take this privilege to introduce Dr. Gupta. He's a very senior person, a very thoughtful academician. He was with us for a number of years. I had close interaction with him. We had lovely time together, and he's always been a prolific teacher, I would say. So he can do the best judgment to this kind of topic, which is in everyday's practice, so much needed for every GP, every internist, every physician. So it is more of a common topic. And welcome, Dr. Gupta. Uh, Waiting to hear from you.
Good evening, ladies and gentlemen. At the outset, I would like to thank Dr. Brajesh Mittal for giving me this opportunity to participate in SHAKEHEART. And I'm going to discuss a very important topic which we all face in our day-to-day clinical practice. That's a hypertension management everyday challenges. And we all know that hypertension is a major public health problem. And in spite of guidelines and available drugs, control rates are abysmal poor. And challenges to improve the control rates are coming from the system, from the patient, as well as from physicians. We all know that cardiovascular disease is a leading cause of global mortality, and India is no exception to it. In India, 28% deaths are attributed to cardiovascular disease, and hypertension is very most important modifiable risk factor for CVD, and prevalence of hypertension in India is 29% and responsible for 24% of CV deaths and 57% of stroke deaths. But the control rates are only 24%, so we are not doing a good job. So before we manage the patient, we have to establish the diagnosis of hypertension. And to establish the diagnosis of hypertension, one has to see that the blood pressure has been measured correctly. And this is a ESHESC consensus document, and they recommend that all these precautions have to be taken care when you are measuring blood pressure in the office. That's the non-smoking, no smoking, caffeine, food, exercise 30 minutes before, quiet room, comfortable temperature, 5 minutes of rest, no talking or during between measurements. Patient should sit comfortably on chair, back rest, foot planted on the floor, uncrossed, arm bare, resting on the table, and it should be at mid-arm at the heart level, appropriate size cuff, validated BP machine, and then take 3 measurements, 1 minute apart, discard the first one and average out the next 2. And so many variables involved, but this is really not practiced in the real life. Even 1% of the clinics and hospitals, they don't follow all the precautions which are listed here. But it is extremely important, just giving an example, one variable, cuff size, can misclassify hypertension significantly. As by this study, which was published just 2 weeks back, cuff size blood pressure measurement trial, in which instead of using large or extra large, they use the regular size, and 39% patients were misclassified as hypertensive and they were normotensive. In contrast, where the regular size cup was there, a too large cup was utilized, and 22% patients, hypertensive patients, were missed. So one variable can lead to misdiagnosis of hypertension significantly, so you can understand how important it is to measure the blood pressure correctly, because labeling somebody as hypertensive, you are asking for lifelong commitment to the treatment. So one has to be absolutely sure before you say somebody that you are hypertensive. Now we have got the cuffless gadgets, watches, apps, and so many things, but they will take time to come into the clinical practice. And to confirm the diagnosis of hypertension, office blood pressure alone is not enough until unless you take repeated measurements at different intervals. So it's always better to utilize HBPM or ABPM. And utilizing office and out of office blood pressure, you have got the both are normal, sustained normal tension, both are high, sustained hypertension, office high and out office normal white coat and reverses mask coat. But in treated hypertensive patients, if both are below the goal, it's true BP control. If both are above the goal, it's a true resistant uncontrolled hypertension. And if it is high office and normal home, then it's a false resistant uncontrolled hypertension. And the reverse is false BP control mass resistant hypertension. After confirming the diagnosis of hypertension, one has to assess the target organ damage as well as global cardiovascular risk. This is again a challenge because it is hardly implemented in day-to-day clinical practice. Majority of the physicians, they just measure the blood pressure and they write the treatment. There are plenty of guidelines, although all of them convey the same message except little bit variation here and there, but the doctors are confused. In fact, every country has its own guidelines. All the guidelines recommend that a lifestyle intervention should be a part of hypertension management, including no smoking, no alcohol or moderation of alcohol, plenty of fruits, vegetable, nuts, Mediterranean diet, less salt, less than 5 grams a day, regular physical activity, weight and waste management, stress management, 7 hours of good quality night sleep, and positive social interaction and connectivity. All these measures are very easy to say and preach, but very difficult to implement. So all hypertension management teams should have a nutritionist and counselor and should look into it as lifestyle interventions are implemented and adhered to. Regarding the pharmacotherapy, this is the algorithm of ESHGSC, and they advocate the single pill combination therapy of RAS blocker plus CCB, oblique diuretic, not at goal, triple combination, not at goal, then additional pill of spironolactone or another diuretic or alpha blocker or beta blocker to be utilized. So they recommend a lot that the single pill combination have to be used. But in spite of all the guidelines recommending it, the current treatment strategy has failed to improve the control rates, and the various reasons are listed here. And one of them is insufficient use of SPC, complexity of the current treatment strategies, physician or treatment inertia is another major challenge in improving the control rates. And the patient adherence to treatment and lifestyle, again, a major challenge. But those systems who have adopted the SPC are doing quite well, and giving example of Kaiser Permanente system in the United States, the control rates are 94%. And it has been adopted by WHO Global Hearts, PAHO Hearts in US, and WHO says this approach has demonstrated general acceptance by government, public, and private stakeholders, and is demonstrating success in increasing hypertension control rates worldwide. We all know that the blood pressure falls during sleep to the tune of 10 to 15%. And in ABPM recordings, you can see here that the first one is normal blood pressure with the normal dipping pattern during the night. The second one is hypertension with blood pressure falling during the night with the dipper pattern. And the last one is hypertensive guy, in which the blood pressure does not fall during the sleep. This is the non-dipper pattern. And these patients are at much higher risk for MACE as well as CVD mortality. So another debate is to cover this and take care of non-dipping pattern. Should we give all the pills in the night, or in the morning, or one in the morning and one in the night. There is a lot of conflicting data. So jury is still not out. But what I would prefer, if the patient is using two pills, at least one can be given in the morning and one in the night. Another challenge is to remember the sex differences with antihypertensive medications. Whenever you are using diuretics, beta blockers, or ROS blockers, one has to remember their clearance is less in women, so the side effects are much more. Regarding the diuretics, more electrolyte disturbance and arrhythmia. Regarding beta blockers, more fall in heart rate and blood pressure. Regarding the ACE inhibitors, more cough and angioedema in women. And of course, spironolactone, more hyperkalemia and gynecomastia in men. So in spite of all the guidelines, in spite of all single pill combinations available, only 14% people are below the goal of less than 140/90 globally. This is the WHO data. And in low and middle income countries, only 8%. So this is really, we are not doing a good job at all. And even in the developed countries, if you look into the USA, in 2013-14, the control rates were 54%, which dropped to 44% in 2018. And India, the control rate are just 25%. So we are not doing a good job at all. So everyday challenges in improving the control rates are coming from the system, lack of healthcare physician as well as paramedics, especially in villages in India, lack of health education, availability of the drugs in the remote areas. But the government has opened the wellness center and opened the Janta stores where the cheap generic combinations are available at discounted rate, and providing insurance by Ayushman scheme to the lower strata of society are mitigating some of these challenges. Physician, the clear understanding of the guidelines is not there. There's a lot of physician inertia in initiating the pharmacotherapy and up titrating and trying to achieve the goal. There's a lot of pharma industry influence on the prescription patterns, and the GDMT is not followed. The less utilization of single pill combinations, counselors, telecommunication, and there is problem of follow-up. A lot of patients, they lose follow-up and they stop their medications and ultimately landing with organ damage and complications. Regarding the patient, health education is a real issue. Difficult to implement lifestyle interventions, cost and side effects of the drugs, because majority of patients are paying from their own pocket because insurance penetration is too low. There's problem of adherence to the medications, although the availability of low-cost generics combination and the government support is trying to help it out. So the bottom line is engage, educate, and empower our patient. That is the key, extremely important. And after empowering the patient takes care of his disease, that's a hypertension. And in spite of all the guidelines, this is the data just published a few weeks from the US. In uncontrolled hypertensives, they found that only half of patients with markedly elevated BP were prescribed guideline recommended antihypertensive combination drugs. So we always blame our patient and system for uncontrolled hypertension and poor control rates, but we are also contributing to it. We are not implementing GDMT as required. So we have to improve upon it and should contribute to control rates improvement. We all faced this pandemic in last 2 years, and we all know, and this is the data from US. It will be published in May, the trends of blood pressure control during COVID pandemic. And here they compared the pre-pandemic and pandemic hypertension control rates, and the hypertension control during the pandemic went haywire. Whether you talk about mean blood pressure or the peak blood pressure, all were high and control rates were extremely poor. Various explanations have been given: staying at home, a lot of stress, change in personal lifestyle, gaining a lot of weight, marked decrease in physical activity, access to normal hypertension clinics were not there, and even access to normal drugs were not there. So these were the various factors which contribute to uncontrolled hypertension during pandemic. Only positive thing which emerged from this was that patients were more willing to accept home BP monitoring, telemonitoring, and teleconsultation during pandemic. Now, every country has to evolve its own strategy to meet the challenges of these listed different hypertensive groups. Group 1 is of asymptomatic, undetected, untreated hypertensive, so you need mass screening. Second group of asymptomatic, detected, untreated hypertensive. They were detected, but still the drugs are not initiated. So these are the silent bombs. Then the third group of asymptomatic, symptomatic, detected, treated, uncontrolled hypertensives. This we discuss a lot. And the last group of uncontrolled hypertensives with comorbidities. Ladies and gentlemen, I would leave with these take-home messages that hypertension control still remains a largely unmet challenge for public health system across the globe, even in developed countries. BP measurement techniques and antihypertensive drugs are not optimally used in clinical practice as advocated by guidelines. Hypertension diagnosis may be improved by detection of sustained hypertension, white coat, and masked by widespread use of HBPM and ABPM. Incorporate lifestyle interventions as part of treatment plan. Consistent 24 hours BP control is favored by proper selection, up titration, and single pill combination of antihypertensives as recommended in guideline. Assess health literacy, cultural sensitivities, and medication payment problems, and deal with empowerment of patient, physician inertia, and adherence to lifestyle and medications. Mobile health technologies and home telemonitoring may improve patient adherence to treatment and improve control rates. So I will suggest 6-step approach to manage hypertension. Step 1, when you have established that your patient is hypertensive, assess the target organ damage and global cardiovascular risk. Empower the patient about hypertension and then decide the shared goals. Step 2, whatever the guidelines you are comfortable with, implement in your practice. Step 3, treating physician and patient have to take an informed shared decision what's the best for the patient sitting in front of you. Step 4, implement lifestyle interventions. Start with single pill combination of RAS plus CCB oblique diuretic, no physician inertia, follow up for adherence, then ensure that your patient has achieved the goal. Step 5, assess your performance, audit your clinic, and if anything is going wrong, correct it to improve the control rates. Step 6, those physicians who are doing a good job should be suitably rewarded. With these, I would like to thank all of you. Thanks for your kind attention, and thank you.
So, Dr. Kala, will you please introduce the next speaker? Dr. Gupta has always been prolific in his lecture. So, please hold on, all the speakers. We proceed for the next lecture. Professor Kala, can you introduce?
So it's my great pleasure to introduce the next speaker, Professor Peter Otashevich, Professor of Medicine from Belgrade University Medical School. He's famous interventional cardiologist, and he's the head of the department. And his topic for this meeting is about the chronic coronary syndrome and about the optimal medical therapy versus vascularization. So quite emerging issue. So Professor Otashevich, it's your turn now.
Hello, everyone. My name is Petro Tasic. I'm coming from Belgrade, Serbia. Once again, I would like to extend my warm greetings to you all and my full appreciation to Dr. Mittal, who was so kind to once again ask me to give a lecture on this distinguished meeting. I'm really sorry that I will not be able to participate in person, but I do believe that this would be an interesting topic that can trigger some additional discussions. So this year's topic of my lecture will be chronic coronary syndrome, optimal medical therapy versus revascularization. Of course, this is one of the toughest clinical dilemma that a busy clinician can face in everyday clinical practice. Indeed, it is not easy to be sure that we selected the best treatment modality for patients with chronic coronary syndrome. There are plenty of discussion on this topic for the last 15 or 20 years, and there is a plethora of papers dealing with this problem. For this specific lecture, I have picked 3 lectures that I believe can shed light on this very, very complex topic. So these are my 3 favorite papers dealing with the subject of optimal medical therapy or revascularization for patients with stable coronary disease or chronic coronary syndrome, as it is used to call now. The first study is COURAGE trial, which was made some 20 years ago, and it basically included more than 2,000 patients who were randomized on optimal medical therapy or PCI. So the main finding of the COURAGE trial is that initial management strategy in patients with stable coronary disease, that is PCI, did not reduce the risk of death, myocardial infarction, or other major cardiovascular events when added to optimal medical therapy. At the time, this was a very, very novel finding. However, a number of other papers followed, and the very important paper is ORBITA. Just to remind you, this is a relatively small trial, only 200 patients enrolled, which basically included patients with single vessel disease who were randomized to PCI or sham procedure. The primary endpoint for ORBITA trial was increase in exercise time 6 weeks after the procedure. As you can see on the slide, PCI did not increase exercise time by more than the effect of placebo procedure. So the conclusion of ORBITA trial is that PCI does not confer any additional benefit in terms of exercise tolerance when compared to optimal medical therapy. It is difficult to talk about this subject and avoid ischemia trial, which was first presented on ACC meeting in March 2019, but was published almost a year later in the New England Journal of Medicine. So just to recall you, ischemia included more than 5,000 patients with stable coronary disease and moderate or severe ischemia who were randomized to initial invasive strategy versus initial conservative strategy. And the conclusion of ischemia trial is that initial invasive strategy does not reduce ischemic cardiovascular events or deaths from any cause over a median follow-up of more than 3 years. Based on these and many other studies, ACCHA provided a guideline last year for coronary artery revascularization. These guidelines were heavily criticized and are subject to a lot of discussion. So this is possibly the key figure from these guidelines, and it can look quite busy, but I believe that the message is relatively simple. If you have patients with stable coronary disease and he or she has symptoms, then you should contemplate revascularization. If the patient has significant left main disease, then you should definitely contemplate either surgical or percutaneous revascularization. If the patient has multivessel coronary artery disease and has low ejection fraction, then CABG is the treatment of choice. But on the other hand, if the patient has multivessel coronary artery disease, normal ejection fraction, then possibly this patient would be best treated by optical medical therapy, because the revascularization procedure, both CABG and PCI, were given 2B recommendation. But these studies are not without problems. In fact, problems included with these studies are quite considerable and may hamper us to reach proper conclusions. So I will give just a couple of problems that are inherent to all the three studies that are previously mentioned. First of all, courage study. Some 1,149 patients were assigned to PCI group, and remember, this study was made on intention to treat analysis. And of these 1,149 patients, almost 143 patients either did not undergo PCI, did not have a bowel dilation, or did not receive stent. In addition, more than 107 patients were lost to follow-up. So all in all, almost 20% of patients were not adequately included in the study. For the things to be worse, when we look number of events in medical therapy group and PCI group, we can see that the number of revascularization being PCI or CABG was actually greater in patients who were assigned to medical therapy group. So it's really difficult to make adequate comparisons between the group when there is such a huge crossover between the groups. Ischemia trial, again, huge crossover. More than 28% of patients in conservative arm were scheduled for cardiac catheterization, and of them, 23% received some sort of revascularization by the end of 4 years. For the things to be worse, almost 12% of patients, that is every 8th patient, received revascularization within 1 year of randomization. Again, really difficult to compare the results. But the worst thing about ischemia, at least in my mind, is that ischemia changed its primary endpoint less than a year from conclusion. So the primary endpoint, which was published when the trial started, was only composite of cardiovascular death or non-fatal MI. But then in January 2018, this primary endpoint was changed to include 5-component endpoint. Orbita itself, although small trial, it's not without a problem. And one of the biggest problems in Orbita is that it actually included 53% of patients who had proximal or ostial disease related to left anterior descending or right coronary artery in the group that was scheduled to PCI, versus only 36% of proximal or ostial lesions in placebo group. That can definitely affect the result of the study, because ostial lesions are known to cause more profound ischemia and are more exercise limiting than non-ostial lesions. If we switch gears and change from endpoints such as revascularization, cardiovascular death, or MI, to quality of life, the things look somewhat different. This is courage trial, and we can see that patients who were assigned to PCI group had better quality of life in terms of less angina as early as month 1 following randomization. And this difference persisted all the way to 24 months following randomization. By 3 years, this difference was lost, and patients who were assigned to PCI and optimal medical therapy group has more or less the same incidence of angina. When we look at ischemia in terms of quality of life, the things are even more compelling for percutaneous or for revascularization, because when we divide patients into groups according to incidence of angina, we can see that patients who had daily or weekly angina have profound increase in quality of life as compared to patients who were randomized to conservative initial treatment. And this effect persists up to 3 years following randomization. When we look at the patients who had monthly angina, the difference is still there, but to somewhat less visible extent. These patients also had less angina by 3 years following randomization. On the other hand, if we look to patients who had no angina, we cannot see any difference between the patients who were randomized to invasive or conservative arms, which is self-explanatory, because if you have angina, then you can hardly distinguish between the treatment arms. Let's switch gears again and look at what factors can also influence the response of the specific patients to treatment. And this is a post-hoc analysis of COURAGE trial, and this study looked at the anatomic extent of coronary disease. This is 1, 2, or 3 vessel disease, and the extent of ischemia as assessed by SPECT in terms of prognosis. Again, this sub-analysis included ejection fraction, and when we included all these variables into logistic regression, it became visible that treatment assignment, that is revascularization or optimal medical therapy, did not play any role into outcome of the patients, nor ischemic burden. The only 2 significant variables were left ventricular ejection fraction and atherosclerotic burden, meaning the low ejection fraction and the higher extent of coronary disease. These patients can benefit more from revascularization than from optical medical therapy. Let's look Body 2D trial in terms of syntax score and long-term outcomes. Body 2D trial included diabetic patients who were randomized to either CABG or PCI, therefore not really a trial that assessed the revascularization versus optical medical treatment. But again, results are very compelling. As we can see on this slide, that patients who had higher syntax score benefited more from PCI or CABG as compared to patients with lower syntax score. Let's come to ORBITA. As I already said, and you probably all recall, ORBITA was essentially a negative trial, meaning that PCI versus sham procedure did not increase exercise time 6 weeks plus procedures when we compare the 2 groups. But when we compare patients who had PCI, we can see that actually in this group, exercise times was increased after 6 weeks following intervention as compared to baseline, which was not the case for patients who received sham procedure. Again, post-hoc analysis of ORBITA trial. The patients, one subgroup of patients had stress echo. And if we compare change in wall motion score index following the PCI and sham procedure, we can see that patients who received PCI had increase in wall motion score index, reduction in wall motion score index, meaning that they have increase in left ventricular contractility, which was not the case in patients who received sham procedure. So in conclusion, ladies and gentlemen, let me tell that decision to revascularize or not in chronic coronary syndrome is very complex. There is really no easy way to make a proper decision, but three key points to bear in mind when making decision is patient preference, presence of symptoms, and an anatomical consideration, that is the extent of coronary artery disease. If we take all these factors into considerations, I believe that we cannot make any wrong decision, being optimal medical therapy or revascularization. Another good thing, if we opt for optimal medical therapy, we can defer revascularization for later. Thank you for your attention.
Right. After listening on chronic coronary syndromes, now we are moving for a very important risk factor for atherosclerotic CVD, that's the dyslipidemia. And to discuss this topic, I have got a very close friend of mine. We are all familiar with him, Dr. Brajesh Mittal, who is the chairman of SHAKEHEART as well as the president of Emirates Cardiac Society. And he is currently deputy medical director and the consultant interventional cardiologist as well as head of cardiology, Medcare Hospital. And he is going to talk on beyond LDL, the management of non-HDL, and to take care residual cardiovascular risk. Dr. Mittal.
I think you are muted. Muted. Yes. You need to unmute yourself, sir.
Thank you, Dr. Gupta. I just want to make minor correction, maybe a slip of the tongue. Not the Emirates Cardiac Society, but I am the president of CSI Emirates chapter.
Emirates chapter. Sorry, it was right.
Thank you. Please proceed forward with the presentation. Good evening, chairpersons, friends, colleagues. My talk this evening is Thinking Beyond LDL, Management of Non-HDL Cholesterol for Residual Cardiovascular Risks. We know that there is a high risk of and high burden of cardiovascular disease worldwide. It's the number one killer. 17.9 million deaths occur each year from cardiovascular diseases, and 31% of deaths due to CVD worldwide. The problem is worse in this part of the world. In the Gulf, CVD is the most common cause of deaths, accounting for up to 45% of all mortalities. Dyslipidemia is the main factor. And in our part of the world, the patients are at least 10 to 12 years younger than those in the Western countries. The locally conducted study showed the prevalence of the risk factors, among which the dyslipidemia showed up as the top, accounting to almost 70%. There are clear ways and mechanisms by which CVD can be prevented to a great extent, and lipid-lowering treatment, statins and beyond, is one of the very important components. Despite all the efforts, there are lost opportunities in the prevention, and most coronary patients do not have optimal LDL control. We know the trials, we know the targets, we have the medications, we have the knowledge. But look at this 2019 data, where the patients of coronary artery disease, when they were studied, only 32% patients had LDL less than 70, although a high percentage of them were treated with statins. So there is an inertia from the physician side, from the patient side, and there is non-compliance, there is inadequate dosing. So the problem remains. So this is one of the lost opportunities in prevention. And the second part of lost opportunity is that despite achieving LDL cholesterol goals, patients remain exposed to a high residual risk of major cardiovascular events, accounting for almost 77%. So statins reduce the event rate by 23%, but what about the remaining almost 77 to 78%? 78% of the risk of a major vascular event remain unaddressed. So we have two opportunities here. We have to intensify the LDL management, and we also have to intensify and think about the non-HDL management. Aggressive LDL cholesterol lowering with maximal doses of statin does not completely eliminate residual cardiovascular risk. In TNT trial, when 10 milligram of atorvastatin was compared with 80 milligram of atorvastatin, there was only 22% relative risk reduction. So even intensive lowering with 80 milligram of atorvastatin reduces absolute cardiovascular risk by only 22% compared to atorva 10 milligram. So there comes the concept of non-HDL cholesterol. It is a difference between the total cholesterol and HDL cholesterol. It encompasses LDL, lipoprotein A, IDL, and VLDL. And it has been suggested that the non-HDL cholesterol fraction may be a better tool for risk assessment than LDL cholesterol. So what is non-HDL cholesterol? It is comprised of all the atherogenic lipoproteins in LDL cholesterol, IDL cholesterol, VLDL, chylomicrons, triglycerides. And the anti-atherogenic lipoprotein HDL is the protective one. So when we calculate non-HDL cholesterol, it is equal to total cholesterol minus HDL cholesterol. So maximum recommended level in general is LDL cholesterol goal plus 30 milligram per dm. That will give you the goal for non-HDL cholesterol. The advantages are that it includes an assessment of all ApoB containing lipoproteins. And the practical advantage is it does not require fasting. It can be easily calculated difference between two well-standardized assays, inexpensive, and it can be used even in patients with high triglycerides. So non-HDL cholesterol was shown to be better than LDL cholesterol for prediction of cardiovascular disease in this trial. But at the moment, most guidelines give the target based on LDL cholesterol, but now gradually we are getting into the guidelines which are towards HDL cholesterol, non-HDL cholesterol also. Like in this AAC guideline, they have given the targets for all three: the LDL cholesterol, the non-HDL cholesterol, and ApoB. So if you see the non-HDL cholesterol in an extremely risky patient, it is 80. In very high risk, it is 100. It is in high risk patient, it is 130. So there is clear importance of residual lipid risk beyond LDL cholesterol. Look at this diagram. This is a very good and important, impactful picture. On the extreme upper left corner, you will see the patient, a typical patient with a good HDL more than 53 and less than 72 milligram per dl of triglyceride. So if that person's risk is 1, so compare it with the risk of somebody who has triglyceride of more than 190 and HDL is less than 30. So their risk is 10 times greater. So increasingly, the risk goes up when the triglyceride continue to rise and HDL continues to be low. So it is not only about LDL cholesterol. Certainly not. Triglyceride is an important contributor to macrovascular residual risk. In PROVE-TIMI-22 study, when patients achieved LDL cholesterol less than 70, but if they were in the category with higher triglycerides more than 200, they were at a much higher event rate, 30 days risk of death, MI, and recurrent ACS, as compared to those who had less than 200 triglycerides. So minded their LDL cholesterol, all of them had LDL cholesterol less than 70. And the same phenomena also apply to HDL cholesterol, which is also an important contributor to macrovascular residual risk. So in TNT study again, with the less than 70 LDL cholesterol in all the patients, when they were subdivided into the quintile of HDL. So the quintile which least HDL were at the highest risk of MACE versus the quintile with the highest HDL with the least event rate. So we cannot ignore the atherogenic dyslipidemia. We cannot ignore the importance of low HDL, and we cannot ignore the importance of high triglycerides. What is normal value? Let us say in trials it was shown that men less than 40 milligram per DL is abnormal for HDL, and for women less than 45 mg per DL is abnormal. And when you talk about triglycerides, generally it is accepted that equal to more than 150 milligram per DL would be considered as high triglyceride value. So this is not a condition which is not prevalent. It is unrecognized, undertreated, and undercontrolled. So proportion of patients with triglycerides or HDL cholesterol abnormalities in one of the studies known as dialysis studies was as high as 45%, and up to in varying degrees from 18 to 45%. For triglycerides, it was even higher. So there is a need to reduce the risk beyond LDL cholesterol lowering by controlling non-HDL, which is mainly low HDL dyslipidemia and high triglyceride dyslipidemia. And then the role of two important classes of medications comes into picture: fibrates and omega-3 ethyl esters. So several lipid-lowering agents help in reducing triglycerides, starting from statins, but the most spectacular result is seen by fibrates and to a great extent by N3 fatty acids. Even PCSK9 inhibitors reduce triglycerides. Now, there are certain differences in the various categories when it comes to HDL cholesterol. The fibrates clearly increase HDL cholesterol. Omega-3 somewhat increases HDL cholesterol, and similarly, statins somewhat increases HDL cholesterol. So fenofibrate has a lipid modifying effect. It reduces triglyceride levels, it increases HDL cholesterol levels, and it changes the LDL particle phenotype. ACCORD lipid trial, the lipid arm of the ACCORD trial, was conducted in comparing the patients with simvastatin alone versus simvastatin plus added fenofibrate 54 to 160 milligram per DL in more than 5,500 patients. So interestingly, this trial showed an important outcome. If we take the whole cohort of the patients, there was no difference in the two groups, placebo versus medication arm with fenofibrate. But when the patients were taken up, those patients were studied who had a high triglyceride level. They clearly were the advantage was very clear in those patients, those who were on fenofibrate. So reduction in number of CVD events in the ACCORD trial according to lipid profile. So in general, it was in a whole cohort, it was not significant, while in the subgroup with high triglyceride, it was clearly significant. And the same data was seen in field trial. So both the trials showed that outcomes were clearly superior in the patients in fenofibrate group when their triglyceride levels were high and when their HDL levels were low. So shown in a different way that impact of fibrates on outcome in atherogenic dyslipidemia, it was in different trials, ACCORD field, and also a few other trials, which clearly showed a benefit in the subgroup with atherogenic dyslipidemia when they were treated with fenofibrate. And it did not apply to those who were not having dyslipidemia where triglycerides were normal. It was also shown in another trial, Safari trial, that fenofibrate and statin combination, it improved complete lipid profile, and it gave clear good reduction in triglycerides. It caused a good rise in HDL cholesterol level, and other components were also favorably impacted. And the combination helped achieve the goal attainment in a much higher number of patients as compared to monotherapy. And fenofibrate has been shown to be quite safe and tolerable. It does not influence the metabolism or pharmacokinetics of statins. Another fibrate we know about gemfibrozil, which inhibits statin glucuronidation mediated lactonization. It was shown to be causing more rhabdomyolysis when given together with statin. So safety of fenofibrate was addressed in the ESC/ES guidelines. That combination of statin with gemfibrozil enhances the risk of myopathy, and its association with statins must be avoided, while there is no or very little increased risk of myopathy when combining statins with other fibrates such as fenofibrate. So it is effective, it is useful, and it is safe, even when you combine with statin. The second group of agents is omega-3. We know that omega-3 are also known as polyunsaturated fatty acids, N3 omega. So there are two types, plant-based and fish-based or seafood-based. So we know that plant-based are ALA, and the EPA, DPA, and DHA are the seafood-based omega. Now, there are lots of preparations available in the market with supplemental fish oil, and there is a clear difference in the prescription FDA-approved omega-3 versus the omega-3 supplements, because the market available supplements do not contain adequate amount of EPA and DHA, and they are mostly as triacylglycerol as compared to ethyl esters, which are present in the prescription medication. So the market-based preparations are short-acting; these are rapidly degraded in the duodenum. So when the patient says that I take fish oils, we don't count that. We believe and we know that these are not going to be medically much effective. The FDA-approved prescription omega-3 covers for 24 hours, sustained release, and absorbed more slowly. How do they affect lipids? In a trial, the 4 gram per day EPA-DHA was added to simvastatin, and from baseline to end of therapy, there was a significant reduction in the median values of triglycerides. Yet another important study was romantic study, in which the 4 gram per day of EPA and DHA combination was added on the background rosuvastatin 20 milligram per day. And in the red, you will see the combination therapy. In the blue, you will see the rosuvastatin alone. And clearly, there was much higher reduction of triglycerides and much better reduction of non-HDL cholesterol, better reduction of total cholesterol, and VLDL cholesterol impressively reduced. So the combination was supposed to be much better. The EPA-DHA combination also showed a different kind of phenomena, in which this was shown in the GC prevention trial, where EPA-DHA 1 gram per day within 90 days post-MI caused a consistent reduction in all-cause mortality. So it reduced post-MI mortality, total deaths, cardiovascular deaths, cardiac deaths, CHD deaths, and also significant reduction in the sudden cardiac deaths. So this is another importance of omega-3 fatty acids. So risk reduction in all-cause mortality for patients receiving Omacor initiated within 90 days of first MI versus control on top of standard therapy provided a clearly survival benefit and reduction of sudden cardiac death. Then there are also another kind of omega-3s, which are pure EPAs. There are two important studies. One is JELIS study, which was a randomized open-label blinded therapy with the pure EPA, and it showed that 19% reduction in major coronary events when pure EPA was given as compared to the control. And this is also, about a very talked about study, the REDUCE-IT trial, where reduction of cardiovascular events with icosapent ethyl intervention trial. And in this trial, also the patients were having a reasonably well-controlled LDL cholesterol with higher triglyceride levels, and they showed a clear benefit with the 4 gram dose of EPA or pure icosapent ethyl. So there are 3 kinds of omega-3 preparations. 2 of these kinds are available in Dubai. EPA and DHA, and treatment EPA alone, and carboxylic acid, which are not available in UAE. So EPA and DHA are actually approved for two indications. One is hypertriglyceridemia, 2 to 4 capsules per day, and post-MI infarction, 1 capsule per day. And pure EPA is approved for reduction of triglycerides in the dose of 4 capsules or 4 grams per day. So guidelines have put them into perspective. So ESCES guideline says that drug combinations for the treatment of mixed dyslipidemia in the high-risk patients and primary prevention patients who are at LDL cholesterol goal of more than 200 milligram per DL, fenofibrate or bezafibrate are indicated. Then in very high-risk patients or high-risk patients with triglyceride level between 135 to 499 mg per DL, ecospent ethyl 2 by 2 gram per day should be considered. Then there is also in the guideline EPA and DHA combination. It can be used at pharmacological doses to lower triglyceride. The recommended dose is 2 to 4 gram per day. AHA Scientific Advisory also added and concluded that prescription N3 fatty acids at a dose of 4 gram per day, they are an effective and safe option for reducing triglycerides as monotherapy or as an adjunct to other lipid-lowering agents. And then the cumulative findings from randomized controlled trials based on GC prevention trial also showed that treatment with omega-3 polyunsaturated fatty acid supplements is reasonable for the secondary prevention of CHT death as a class 2A recommendation. So, ladies and gentlemen, friends and colleagues, these are the major highlighted points of this presentation, that cardiovascular disease remains the leading cause of death and a major challenge to health systems. Overwhelming evidence supports the high clinical value and safety of tighter LDL cholesterol targets in preventing major cardiovascular events, a concept that is increasingly adopted by latest guidelines. Atherogenic dyslipidemia is a main contributor to the residual cardiovascular disease risk beyond LDL cholesterol levels. Although very common, it is yet underdiagnosed and undertreated. Triglycerides and HDL cholesterols have an important role in cardiovascular disease. However, lipid management has been essentially focused on LDL. So what are the safe limits? Triglyceride is safe when less than 135 mg per DL, should be really considered high when it is more than 200 mg per DL. HDL more than 40 mg per DL in males and more than 45 mg per DL in females should be desirable. Targeting the residual atherogenic dyslipidemia is gaining increasing interest as an essential component of anti-atherosclerotic therapy. And to target this, there are two main options beyond statins: as fenofibrate or bezafibrate, then prescription omega-3 polyunsaturated fatty acids. Both of these classes of agents can significantly reduce the added risk of fatal and non-fatal cardiovascular disease associated with residual atherogenic dyslipidemia. Thank you for your kind attention.
Thanks, Dr. Mittal, for excellent presentation on dealing with residual risk in patients of dyslipidemia. And now I would request Dr. Sachin to introduce the next speaker.
Sure, sir. As we know, the coronary artery disease and the heart diseases have been very uncommon when it used to be young ladies and ladies in particular. And during last 2 decades, the incidence and prevalence of the heart diseases have increased significantly amongst the women. Even any lady coming to the ER with chest pain at whatever age group, because in the part of the world where we practice in UAE, we have seen cases even in third decade of ladies presenting as acute MI. So the risk is now equal, I think, if not more. And to deal with the topic, Dr. Laila, who is a consultant cardiologist at King's College Hospital, London, Dubai, is going to speak. And her topic is, how do you mend a broken heart? Women need care. Dr. Laila, the stage is yours. Please, I welcome Dr. Laila to start her talk. Thank you.
Assalamu alaikum and good evening, ladies and gentlemen. Today I will be speaking about a very interesting topic, which is related to women and cardiovascular and heart health. And the title of my presentation, as you can see, How to Amend the Broken Heart, Women Need Care. This slide, I'm sure that you've seen this slide several times, and this statistics that cardiovascular disease is the #1 killer in men and women in the United States and worldwide. And the women typically, the good news is that women typically develop cardiovascular disease 7 to 10 years later than men, of course, for reasons that we know about, the hormonal being one of them, and how the hormone they protect women from cardiovascular disease. This graph shows the recent data from meta-analysis of 10 large cardiovascular outcome study run by Timmy Group, comparing sex differences in outcome in patient presented with non-STEMI MI, presenting with a non-STEMI, and we can see the unadjusted risk or crude risk for MACE and all-cause mortality. It shows that women tend to do a little bit worse than men, but when we adjusted for adjusted risk according to the age and comorbidity, we found that women do a little bit better than men on average. The other cardiovascular diseases that women are more likely to experience than men, it is one of it myocardial infarction with non-obstructive coronary arteries, or MINUCA. And this is MINUCA, actually, it's a spectrum of diseases that includes so many other categories, like Takotsubo cardiomyopathy, microvascular dysfunction, and spontaneous coronary artery dissection, and plus other diseases. And MINUCA, it's really kind of like when a patient presents with all the signs and symptoms of acute myocardial infarction, but when the patient goes for coronary angiography, the coronary arteries are totally normal. So if we come back as well to a heart failure, and we see that fewer women develop heart failure with fewer comorbidities and fewer ischemic heart disease compared to men, and we know that women, they have higher prevalence of HFrEF and HFpEF compared to men, and pericardium cardiomyopathy is a unique form of HFrEF in women. The reasons are unknown. Maybe it could be sex hormones related, or it could be the adaptation and a different response to the arterial stiffness, and different responses to the non-conventional cardiovascular risk factor like hypertension and diabetes. So the exact mechanism for this is unknown, but still work is going on. I just included some other cardiovascular disease risk factor in women that I kind of like divided it into two things, divided it into one, which is I call it physiological changes that then the woman can go through. One of it is the pregnancy, and the other one is menopausal. Of course, menopausal and pregnancy, they consider as cardiovascular disease risk factor, but there are other things as well, like polycystic ovary disease, like autoimmune disease, which is more commoner in women than men. But I'm going to talk, for the sake of the time, I'm going to talk about only the pregnancy and menopause as a cardiovascular risk factor in women. And of course, the adverse pregnancy outcome like hypertension, which is during pregnancy, which can be divided into preeclampsia, gestational hypertension, eclampsia, or HELP syndrome. And of course, other things that could happen during pregnancy, like gestational diabetes and preterm birth, they all increase the adverse cardiovascular event, which is the cardiovascular disease and a stroke in women by 1.5 to twice compared to if a lady, she is not being pregnant. And then the other thing that I would like to highlight here is the menopause. We all know that ladies who are postmenopausal, they are more at risk of cardiovascular disease. But if you look at the graph on the left-hand side, you can see that that it's not only coronary artery disease, but also other heart disease like aortic stenosis and atrial fibrillation. They are the postmenopausal women. They are more prone to these diseases, and the earlier the menopause, the higher the risk for these diseases. And there's a data from UK Biobank to study surgical and premature menopause and look at the set of the outcome in women comparing natural and surgical menopause, and found that the ladies who are naturally menopausing but less than 40 years of age, they have a risk factor for cardiovascular disease up to 36% compared to the surgical menopausal in these women to 87%. And as we know that the other thing that is well known, that the premature menopause is associated with development of other conventional cardiovascular risk factors like hyperlipidemia, hypertension, and diabetes type 2. And you can see it on the right side of this graph here, which shows the differences between surgical, natural, and the menopausal woman or after 40 years of age. One of the diseases that is very common in women that I would like to highlight in my presentation is called Takotsubo cardiomyopathy, which is commoner in women compared to men. And they've got different names like broken heart syndrome, stress cardiomyopathy, and apical ballooning syndrome. And the characteristic of this disease, that they got severe LV dysfunction, that most of them, but not always, the patient could make a good recovery. And I'm going to go into prognosis later on in my talk. And the name came from the octopus trap, the Japanese octopus trap, but looks like which the heart, the left ventricle looks like it during the episode of Takotsubo cardiomyopathy or broken heart syndrome. Previously, Takotsubo cardiomyopathy was not very much kind of like a common, but unfortunately, in the years, the incident of it has been increasing over years. Is that because maybe the better diagnosis, because this is a condition can be easily misdiagnosed or underdiagnosed. So the criteria for diagnosing and defining Takotsubo, it is the transient hypokinesia, akinetic or dyskinesia of left ventricle, mainly in the mid-segment with or without apical involvement. And it is often triggered by stress, but it could not always be there. And the stress could be physical, or it could be emotional stress, loss of a spouse, and financial loss, or physical, like cancer or limb amputation. So this could lead to the stress-induced cardiomyopathy. And on the angiography, you will find that there's absence of obstructive coronary artery disease, but there is new ECG abnormality and modest elevation cardiac troponin. And as I mentioned at the beginning of my talk, this is part of the MINUCA. And of course, we have to exclude other causes that will lead to ECG change elevating in troponin, like myocarditis. The pathophysiology of Takotsubo, it's not really understood, but a lot of hypotheses is there. One of them is the catecholamine cardiac toxicity, and all depend. They're talking in this hypothesis. They're talking about how the receptors, different beta receptor and alpha receptors, and the distribution in the apex of the heart and the base of the heart, and how do they respond differently in terms of in the view of catecholamine rush that happened during physical or emotional stress. And there is a different variant of Takotsubo. One of it is called inverted inverted Takotsubo, where there is not the classical presentation of Takotsubo, when you can find the hyperkinesia, in this case of the apex and mid-ventricular ballooning. And this happened in 23 of cases where younger population compared to an elderly one, which they present with typical Takotsubo. The clinical feature, as I mentioned, this is ventriculogram, and you can find that there is the typical is the ballooning, and you can of the apex, and you can see this is the blue dots indicates the hypokinesia, and the red one is the hyperkinesia, and then you've got different type of clinical features of the stress cardiomyopathy. And as I've said, they're typical and atypical presentation for it. The majority of it is typical, and it's postmenopausal and presented with chest pain and dyspnea that mimic acute coronary syndrome. And you've got ECG and troponin changes, and you can find on the echo dysfunction wall motion abnormalities, usually, as we mentioned, in distal left ventricle, but they are as well atypical presentation, less frequent, more common in men, younger age they present, and there is no evidence of any stressor. So this is a case that I would like to highlight on it. Is it was a 53-year-old lady who was swimming and got stung by a stingray, and then she was in stress because of the pain from the sting, and then she had to swim all the way to the beach. And when she arrived there, she was in pulsative activity cardiac arrest, and she had to be resuscitated and brought to the casualty. And this is her investigation, and it showed that she had Takotsubo cardiomyopathy. So what is the ideal treatment for it? Unfortunately, there's no specific guideline for Takotsubo, and we follow the acute coronary syndrome and acute myocardial infarction and heart failure guidelines. And then acutely, we have to treat them with aspirin, heparin, beta blocker, ACE inhibitor, or ARB. And then chronically, it shows that beta blocker we use beta blocker and ACE inhibitor, but it showed that beta blocker does not prevent recurrent attack, although we say that this is stress related and there's a catecholamine rush in this disease, but still beta blocker does not prevent recurrent attack. And of course, stress management is the best treatment for it. But the question that arises with discontinuation, when do you discontinue the medication after the patient get the full recovery? So that's the question that needs more study. The prognosis of this case is not as benign as we thought initially it will be, and the rate of inpatient complication in one big study that was done, including more than 1,700 patients, it shows that the rate of patient complication was similar in Takotsubo patient compared to patients who were admitted with acute coronary syndrome, and the long-term follow-up major adverse cardiac and cardiovascular event was 9.9, and the rate of death was 5.6 per year compared to the patient who had acute coronary syndrome. So it's not as benign as we thought. The majority of patients they recover, but still some of them they have a long-term mortality and morbidity. And this is shown in this Kaplan-Meier graph, which estimates 10-year outcome in patients with Takotsubo cardiomyopathy. Thank you very much.
So now we have some good time for discussion, and all the speakers who are available can join for the panel discussion. So Dr. Gupta, you can initiate some questions if you see. Any audience questions?
Yeah, first we can take if there is any audience questions.
I don't think so there are any audience questions. We have to see in the comments. It has to be in the comments.
Yes, so there.
Maybe
Yes.
if you, Brajesh, if you wouldn't mind, I would like to ask my colleague regarding the high-risk bleeding population? Because
Yes, please.
it's an emerging topic, and it's quite important. But my question would be, do you calculate in all patients the high bleeding risk, or how do you do that in daily practice? Because it's quite an important and, well, from the practical point of view, quite important issue.
Actually, to be frank with you, we don't calculate at each cases, but having gone through the literature and seeing that these are the high bleeding risk cases, the moment we have such a patient identified, we know now these are the risk factors, we would go on to a protocol of antiplatelets, which should be on the lower level. We may not go for the higher end antiplatelets. We would go by the risk of the angioplasty and the risk of the stent thrombosis, and use it, weigh it properly. But having said that, the ideal way to go would be with this risk scoring, and then decide what is your risk, and then go ahead and plan a strategy. So I'm at this stage. It was more a learning experience when I prepared this talk, and I'm sure it will be beneficial as we go along the rounds and make sure that I was talking to my clinical pharmacologists and the young doctors here that we should make it a practice so that when I say the bleeding risk is this percentage, I mean, it should mean equivalent everywhere. So we have a group of patients who come in with multiple risk factors. Their platelets are on the lower end, they have a GI bleed, and at the same time, the troponin is in the thousands. So it is a challenge always, and quaternary centers will tend to receive more of these patients, and a multidisciplinary team approach will help us to develop the correct strategy.
Yeah. So, Dr. Arjun, sometimes do you believe that suppose somebody is coming with a STEMI and you will just
Huh?
uh, get the STEMI 3 flow and do not put any center for stenting? Do you consider this at times in high bleeding this patient especially?
I have not stopped that only without stenting because active bleeding and STEMI we have not managed. But I can tell you that we did an angioplasty and then somebody calls up and tells the hemoglobin is only 7. So at the moment, to defer stenting has not been considered a great option because we know the risk of reocclusion is also high, especially in an anterior MI. But that's a good thought. I mean, I don't know whether you would be confident enough to live without a stent because the problems of bringing the poor patient back to the cath lab and planning the stenting, it is a difficult issue, but that is something which can be considered. But if there's a very high clot burden and then we are not able to get a good anticlate flow and slow flow, we might consider that option.
Yeah, Dr. Anil, I also face the same scenario. A
Mhm.
patient admitted with GI bleed
Right,
under gastroenterologist, developed chest pain and anterior STEMI.
right.
So, what sort of antithrombotics we should?
We would straight away take the patient up into the cath lab and then
Right.
see if it is a STEMI, there is no doubt about it. A non-STEMI, we would manage medically and then stabilize. But in a STEMI, we would take up, see what is the clot and give minimal heparin. Maybe we would give 3,000 to 4,000 heparin and then go ahead and do the angioplasty and the stent. And then it's only initially we will still have to give a dual antiplatelet and wait and watch how the GI bleed progresses. And if forced to, we have left the patient on one antiplatelet. At least 3-4 patients we have managed with single antiplatelet without without a dual antiplatelet therapy, and then crossed our fingers. But the risk is always there of an immediate stent thrombus. As I showed you, with bleeding risk, there is higher thrombotic risk also. You have to
That's
understand
right.
that. Yeah.
Yeah. So there are two scenarios actually with a high bleeding risk. One is active bleeding at the time of incident procedure,
Hmm.
and that is slightly a different scenario. Like you said, uh, high active bleeding in the patient, and suppose it is non-STEMI. And if you
Right.
want to manage him conservatively, still you need to give some antiplatelet.
Correct.
And
So
so
that
this is
would be
one scenario at the acute stage with acute bleeding. And second is high bleeding risk, like in a chronic kidney patient that today he is not bleeding, but he carries or she carries high bleeding risk So then you have the stent which you can put in within 3 months, 1 month you can stop dual antiplatelet. So there are also
The,
two divisions of the same problem.
so the thing is, gastroenterologists still prefer aspirin over clopidogrel. You would think that you'd be worried about erosive gastritis or
Yeah,
ulceration, but
yeah,
their
yeah.
choice of antiplatelet is still aspirin and not clopidogrel. Dr.
Okay.
Kala, what are your thoughts? Would you say in a bleeding patient, aspirin alone as an antiplatelet may still be preferred? Dr. Sachin?
Well,
Yeah,
yeah.
let Dr. Peter Kala respond first. Peter Kala, Dr. Peter Kala, please go ahead.
Okay. So I think that we always have to think about shortening the duration of dual antiplatelet therapy. And nowadays, for me, the question is more about which drug should we continue. So should it be aspirin, or should it be some more potent therapy? Because we have also quite good data for the ticagrelor in monotherapy, and so we always have the balance, or try to manage the balance between the ischemic and bleeding risk, and based on these parameters, we decide.
So, Dr. Mittal, there is no one set rule. We always have to individualize. That is what I cannot say. I will do this for every given patient. That's the problem.
There's a controversy among the among the gastroenterologists also, sir. Like our gastroenterologist prefers clopidogrel. He is not comfortable with aspirin. And what we try to do in our center is to minimize the duration of the dual antiplatelet rather than keeping them on a single antiplatelet. And then, as you say, keep the fingers crossed and then assess. Another situation that I wanted to discuss is that some of the patients, they present with atrial fibrillation along with the acute coronary syndrome to add to the problem. And then what should be the duration of the triple therapy, and then how to shift back to the single antiplatelet therapy also. This is also a question, because sometimes they do not present as an active GI bleed at the time of the index event. But because there has been a history of GI bleed, we have to be cautious. So atrial fibrillation along with patient going in for a PCI, or PCI patient developing in AF. So what should be the strategy for the anticoagulants? Or
I think that is very clear. 1 month of triple therapy, that is dual antiplatelet with anticoagulant. After that, single antiplatelet with anticoagulation for the rest of the 11 months. And at the end of 1 year, you continue only the anticoagulant.
For acute coronary syndrome, it can be still shorter for 1 week, because for chronic coronary syndrome, it is 1 month triple therapy. For acute
I'm not sure about that 1 week. I have not gone through.
Still, it is 1 month. Triple therapy is still 1 month after any
acute coronary syndrome.
Yeah.
For chronic or for acute coronary syndrome?
For both, or after PCI.
Okay.
Yeah. So I have an additional supplementary question in this, that sometimes it is a dilemma when we encounter a patient for the first episode of ACS already on full dose of NOAC. Now, what should we do at that time, at the time of procedure? What precautions? How much heparin to give? This is sometimes a dilemma for me, especially.
I don't think there is one answer to that. You have to give a half dose heparin, take them up, and then I don't think even ACT will tell us how much effect with NOAC. And so again, it's all a bit challenging these things. We still have to wait for the answers. Again, when we talk about monotherapy of clopidogrel after 1 month, I'm a bit worried about clopidogrel resistance, especially in the patients post ACS. So I would prefer to continue aspirin for after 1 month rather than clopidogrel. But the guidelines have come out with even using clopidogrel as a single antiplatelet. We know Brilinda ticagrelor is very good for 11 months. I have had few patients on ticagrelor alone. But clopidogrel alone, I am just that bit worried, though clopidogrel resistance after the ACS may be much less. What are your thoughts of clopidogrel alone? Any thoughts?
If I am able to give, I will rather prefer Brilinta as a single agent.
Correct. Yeah. That we are all more confident.
Yes. And we have some patients who did pretty well on a single Brilinta therapy.
Brilinda, after the first week also, maybe we may be able to hold on to them. I have a ROTEM test which will tell us the platelet activation. And if we are forced to give only clopidogrel, I use that to see the clopidogrel sensitivity. And that also helps us to manage patients with aspirin with clopidogrel, especially in the high bleeding risk, and we can avoid ticagrelor.
Right.
And what about the
So,
switch, sir? How early we can switch from clopid from in the high bleeding risk cases from ticagrelor to the clopidogrel? How
See,
soon one can
most
attempt
of the
for a switch?
modern science, the endothelialization is reasonably good at 30 days. So I would say 30 days would be a good time to switch over to the or step down antiplatelet therapy.
okay, I have a very simple question from Dr. Peter Kala, that when we talk about high thrombus burden, so how do we decide and define exactly what is high thrombus burden?
Well, it has to be at least quarter of the diameter of the vessel, and it should be well at least 10 millimeters long, but even longer. And of course, this is difficult to define exactly because we have only the angio parameters that can tell us the risk of or the amount of thrombus burden, because otherwise if we would use the intracoronary imaging, we would get much better information.
Hmm. Okay, thank you. Dr. Gupta, there is
Right.
a question from audience about
Yeah.
ABPM.
Yeah, I think what is the latest cutoff value for ABPM? So let me answer this. If you have got daytime average, if it is beyond 135/85, your patient is hypertensive. If you have got a 24-hour average, then it should be beyond 130/80 and your patient is hypertensive. If you take a nighttime value, if it is beyond 120/70, then your patient is hypertensive. So these are the three cutoffs which we take on ABPM to diagnose somebody as hypertensive.
Okay, yes,
Dr. Mittal, can I ask you something about your
yes,
talk? It was
yes,
a very
please.
nice revelation of not to stick on to LDL targets alone. But I remember till 2012, I was sold on the HDL concept. And now, to talk about the elevating HDL, nothing is happening in scientific circles. What are your thoughts of? Do you think HDL will make a comeback, or is it just you also talked about all the other non-HDL therapies,
Yes.
non-LDL, non-HDL therapies? Yes. So, any
Yes.
thoughts of HDL coming back, or we can forget about it?
Well, so why we talk of non-HDL? Because we clearly understood that we can't do much about HDL.
Hmm.
So, so we have put HDL aside. That is it is like an obstinate child. We can't touch it much. So better think about non-HDL. So the good part is on one side, and rest of the other part is on the other side, and just focus on the non-HDL. The problem, we are all knowing that different medications came, niacin and even niacin ER, and then liraglutide. So many things came and went. Nothing worked for safely. Nothing worked safely. Only niacin can increase, but it didn't increase significantly. Now, what increase HDL to some extent, I have shown that fenofibrate, it does increase HDL. There is a lot of controversy about statins. In our practical life, we have seen that more often than not, statins reduce HDL rather than increase HDL, although trials sometimes say differently. So the point is that we do not have enough means to increase HDL. Tomorrow I have a talk on a inclisiran. So inclisiran has shown about 8% increase in HDL also. So there are agents which are showing somewhat some benefits, but I think the best at the moment is fenofibrate. And contrary to what we normally think that omega 3s help in increasing HDL, they do not. That is also we have to keep in mind. They only reduce triglycerides.
I have
Yeah,
a
I
little.
think I
Go ahead.
think that Dr. Mittal, what he's saying is absolutely correct because we have got nothing to raise HDL right now. And in fact, HDL theory itself is a question mark right now because it has not been supported by Mendelian randomized trials also. In fact, the CETP inhibitor story has almost killed the HDL theory. In fact, the latest CETP inhibitor, that is omicetrapib, is coming as a LDL lowering agent than the HDL raising agent. It has given a very good LDL reduction of 39 to 40%, and it is under consideration by FDA for approval. So that's why the HDL is almost not discussed these days. We discuss about non-HDL and apolitile and all those things.
Yeah. So the bottom line of the talk is just a reaffirmation that once we get to the target of LDL with maximum tolerated statin, always look for non-HDL also, and then treat it accordingly. It has found to be very, very useful, extremely useful. So all the trials have clearly divided the patients in two groups. Their LDL is controlled well, and now if high triglyceride or normal triglyceride. So this is how they've differentiated. So we have to look for this.
There have been concerns, sir, although in your talk also you showed that European Society of Cardiology has cleared statin along with the fenofibrate use.
Yes.
But ACC guidelines still continue to keep statin and fenofibrate, even fenofibrate, into black box warning. So, and we know that this omega-3 fatty acids also reduce the triglycerides by around 40 to 50%. So will it be an appropriate strategy to combine statin with an omega-3 rather than a fenofibrate?
The problem of omega-3 is these are good medications for triglyceride reduction, but the problem is they do not affect HDL much, and they increase LDL slightly. So this we have to keep in mind. So,
Still, I would be worried about using high dose statins with fibrates. 20 atorvastatin or 10 to 20 atorvastatin. So you should keep statins on a lower level when you combine it with.
That's right. No, I agree with you. So the moderators and chairpersons, I will request our honorable speaker, Professor Peter Kala, to conclude this session because this has been, I suppose, I've received some comments on my WhatsApp that it's been a good session. So I would request you to conclude, and from my side, I'm very much thankful once again to all of you coming over, sparing time of 2 hours and stimulating such nice talk and discussion. So please, Dr. Peter Kala, before we wind up this session.
Thank you very much. First of all, thank you very much for your kind invitation and your continuous activity in the education. And I think that this session was really extremely important because there were overview of quite a lot of very critical issues that we are dealing with in cardiology, and not only in interventional cardiology, but in general cardiology. And I think that it was very nice demonstration that that the patient doesn't stop, the care of the patient doesn't stop in the cath lab, but it continues for forever. So thank you very much, and good luck with your care.
Thank you.
Thank you very much. It was a nice interaction with all of you. I really enjoyed seeing all of you after a long time. Thank you very much again, Brajesh, for giving this opportunity.
Thank you. It's my honor.
I could not introduce because my name told me that I'm sorry.
Thank you, Dr. Mittal, for giving me this opportunity to be a chairperson. The talk have been very enlightening, so as of Dr. Peter Kala and Dr. Pradeep Gupta and Dr. Laila as well. All have been very wonderful. Thank you very much.
Thank you. Please stay on for the small inaugural session.
Sure.
And then subsequent talks, and all of you are still part of us and part of the faculty and part of the panel today and tomorrow. And your inputs will be very, very much valuable. Thank you.
Thank you.
Thank you.
Good evening, dear friends, colleagues, the esteemed faculty members. This is my immense pleasure to welcome you all in the sixth edition of annual conference on saving deaths and damages from heart attacks. We started this movement in 2015 in the month of April, first week, when we held our first meeting and first launch of uh, the concept of saving deaths and damages from heart attacks by the name scale, and we had our first annual meeting in November 2015. And then we realized that it has to be more generic. Scale was very specific. So in the end of 2019, we launched with the different name Shake, Saving Heart Attacks Key Efforts. And the idea was to expand it not beyond the medical realm, to take it forward to the public, and we did some events for the public education. How are we contributing? We are doing this mostly by education. Education is the key. And we are in a good state as compared to many other illnesses like cancers, where we don't have much control, we can't prevent much, we can't treat much. Here we are in a situation, we are dealing with an elephant which is uproaring, but still it can be tapped, it can be controlled, it can be put in a straight line. So cardiovascular diseases give us an advantage that a lot can be done. A lot of lives can be saved. I usually tell my patients when they deny the medications, when they resist the medication for cholesterol control, for blood pressure control, I tell them one thing. Everybody applauds me when I treat a patient with acute MI successfully, and I'm a hero. I think I should be a bigger hero when I prevent it, and then he understands. So the problem is prevention is not as easily quantifiable as saving the life of a person who has already suffered. But who should be given more marks? The one who prevents or the one who treats? So I believe there is a lot of scope in prevention. Based on this, based on this concept and idea, this is my humble effort, more or less in a very solo way, to apply these principles to derive some pleasure and give some benefit to our patients and also to our society. So this is the sixth annual conference. Besides, we have had multiple smaller meetings at times, including a few for the general public. This is being done on a hybrid platform. Today it is only virtual. Tomorrow it will be hybrid, which is for me also been a challenging task to take it forward. But the important part is that I've been so blessed to have a stream of wonderful colleagues, of very highly acclaimed people, established cardiologists and physicians in the world who have joined hands in delivering their thoughts and their ideas and putting the key message across. So I welcome you all to join and participate, to learn and give your comments, to encourage us. Your participation will encourage us in a bigger way, in a better way, year after year. We do not have any means to exactly quantify and tell you that how much did we achieve, but I am sure the knowledge percolates, it carries forwards. It is also like infection, a positive infection from person to person. So let us all work towards it. We have an exciting program. We have faculty from 7 different countries. We have senior people, we have researchers, we have pioneers. We have almost 40 faculty members, 7 sessions. Some are the focus talks on newer therapies and newer medications. You can go through the agenda, it is available. And we have at least 25 talks. Some are smaller, some are bigger, but divided in a very crafted, in a very different way. So I need your blessings to carry forward this effort. I welcome you, and I would be happy to hear feedback and comments, both positive as well as negative. What else can we do what else can we take through this program. At the end of at the conference, please fill in the feedback form, and once you fill the feedback form, you will receive a certificate. The certificate of CME will take time because the DHA accreditation is under process. It doesn't come soon. It may take a couple of weeks, but we promise you, our team at the back end is working hard uh, to achieve it successfully and to complete all the desirable protocols which should be done. With this thought, I acknowledge our patron, Dr. Azad Mupen, a physician, an entrepreneur, and also a philanthropist. He was very, very kind enough to accept the patronage of Sheikh in the end of 2019 when it was founded, and his blessings are with us. Though it is an inaugural speech, but I will take this opportunity at the same time to thank you all those who have supported immensely in carrying out this program. Our backend team has been working hard for last 1 month, day in and day night. The last 2-3 nights, I remember that for some reason or other, if I woke up, I found that there was some or the other message going on in our group of people who are working for this conference. So I take this opportunity to thank them, and as well as I thank all the sponsors who have made it possible. They have contributed for the benefit of the society, for the benefit of the healthcare physicians, to take this educational program forward. So thank you, everybody. Welcome once again. And now I invite our patron, Dr. Azad Mupen, to deliver his inaugural speech. Thank you.
Welcome everyone to this fantastic program, the Sheikh Initiative. This is a moment which is actually a crusade by a single doctor in various areas of healthcare, especially those pertaining to the area of heart. Dr. Brajesh Mittal, who is my colleague, has been doing this crusade over the last 5 years, and he has done it very successfully. Single-handedly, I should say, and he has helped in increasing the awareness as well as serving large number of patients and saving lives by educating all of us about the various aspects. Now, this year he has focused on saving lives and preventing deaths by educating people about acute heart attacks, acute MI, as we call it, myocardial infarction. And this is, as you know, one of the most important causes of death in the present day. There are various aspects to it. How can you save somebody who has an heart attack? The first thing is to have that awareness in the patient himself, that this is something which is serious. Many people just think that this is gas or some other pain, muscle pain and all, just dismiss it when there is a pain. And people, especially people diabetes and all, they don't even have a pain, and they have to know what are the symptoms that they should be looking at. So that's one of the important things, the awareness. Then from the people who are actually around the patient who gets this, they also should be taught about the way in which this patient has to be transported to the hospital, preferably in an ambulance, as well as in case, now God forbid, something happens like an arrest and all, what is to be done. Then even the doctors, what is the best way to treat patients who are having a heart attack, how it has to be tackled, the various ways it has to be tackled. I'm not going into the details. This will be discussed in this 2 days program. I just want to congratulate Dr. Mittal, who has been doing this very religiously every year, and he has taken such troubles to take it to this level. He requires an applause as well as he should requires our support, and may God bless him for whatever he's doing for mankind. This is a very, very important area. We are losing significant number of people to this malady of heart attack. Not only old people, but very young people. We have a lot of examples of youngsters, including professionals, just succumbing to heart attack. So let us support him. Let us hear from him as well as the other very eminent people who are speaking in this today program. I once again wish him all the best and may God bless him. Thank you.
Thank you very much, sir, for your kind words and your unrelenting support over and over. Thank you very much. Dear friends, with this, we come to the conclusion of inaugural session and wish you all the best. Hope you will enjoy these 2 days proceedings. And we proceed forward for the next scientific session. Thank you. Good evening. I can see Dr. Javeria. Good evening.
Hi, good
Dr.
evening.
Mohammed Salah.
Good evening.
It's my pleasure to welcome you. My pleasure, my immense honor to welcome you. So this session is a focus session on edoxaban. Principally, will be chaired by Dr. Javeria, and I will be just a co-chair. So please, you take over the proceeding, Dr. Javeria.
Okay, thank you very much, Dr. Mittal. So this symposium will focus on the management of atrial fibrillation. And as you all know, this is the most common cardiac arrhythmia that you deal with. And you probably think you know everything about it, but you still get patients where it becomes very tricky, where the decision becomes very difficult. So I think hence comes the importance of this session. We have 3 eminent speakers. I'm pretty sure you're going to enjoy their talks. So we're going to start with Dr. Firas Al-Ani. I don't know if he's with us already. So Dr. Firas Al-Ani is a consultant cardiologist. Do we know if he's joined? Okay. So it seems like he's not. He did not join yet. So maybe I'll introduce Dr. Mohammed Majdi first. So Dr. Mohammed Majdi, are you with us? I see you online.
Yeah, assalamu alaikum. How is everyone?
Hi. Good to see you.
ازيك دكتورة جويرية يا اخبارك؟
Alhamdulillah, Allah يسلمك.
May I suggest you one thing, doctor?
Sure.
We have the recording from Dr. Firas Alani, so we can play his presentation recorded by the time he will join us. So we can start his presentation. So
to my understanding, we're going to display the pre-recorded sessions, and then we will take the question and answer them at the end.
That's right. Yes.
It will be live at the end of session, right?
Yeah. That's right. So first talk is from Dr. Firas. So admins, please arrange to play his recorded lecture.
Hello, good evening. My name is Dr. Firas Alani. I'm an interventional cardiologist by background and the Chief Academic Officer at the American Hospital, Dubai. I will be talking today about oral anticoagulation and the role of several NOACs, and we're going to go over a review of this multiple trials and try to identify some of the minute subtle differences, and we'll address the ENGAGE trial, which is a TIMI 48. In this slide, you'll see the timeline of the studies as pertains to the NOACs. Back until 1993, we had warfarin as the main drug available. However, in the last decade, about 4 studies came about, and paving the road to the 4 novel oral anticoagulants, the Relive or dabigatran, Rocket for the rivaroxaban, and Aristol for the apixaban, and finally ENGAGE AF TIMI 48 for the edoxaban. These trials were comparing these drugs to the gold standard therapy, which is warfarin. And as you can see, these were in a randomized fashion and obtained the FDA approval, well-conducted studies. And the number of patients were quite large. Some subtle differences in these 4 trials. Here you see the 4 trials lined up in the RELY, and ROCKET, and Aristotle, and ENGAGE. In the RELY, they adopted 2 doses, 150 and 110 for the dabigatran. This is pre-protocol specified. In other words, there was 3 arms in those studies: warfarin arm, 150 milligram and 110 for the dabigatran. The same thing was in the ENGAGE. There was 3 arms, warfarin and 60 and then 30, all in randomized fashion. And then in the ROCKET and the Aristotle, there were only 2 arms, the warfarin versus the drug in rivaroxaban and ROCKET and Aristotle, and apixaban and Aristotle. As we all know, the dose frequency for rivaroxaban and ENGAGE is once a day, while the dose frequency for apixaban and dabigatran is twice a day. These are, again, some subtle differences to point out. There was no initial dose reduction deployed in the study of the RELY. However, there was a pattern, or there was a pre-specified protocol of initial dose reduction in the rest of the trials, the ROCKET, Aristotle, and ENGAGE, and these were based on a combination of factors that has to do with creatinine clearance and weight, as well as use of concomitant drugs such as PGP inhibitors. The dose reduction as a result occurred about 21% in the ROCKET and about 25% in the ENGAGE. These were dose reductions on randomization. So patients will be randomized to one arm versus the other, and if they are randomized to the drug arm, whether it's rivaroxaban, ROCKET, or Aristotle, or apixaban and Aristotle, or edoxaban ENGAGE, and in that arm they would have then a dose reduction before or after randomization, or just at, I should say, at randomization. In ENGAGE, they also allowed another level or another juncture of reduction in dose after randomization, and which makes sense because, and this is unique to the study, because these patients were followed by anywhere between 3 to 4 years. So even if they have not met the criteria for dose reduction early on, they could have met it those criteria 2 or 3 years later while they're still in the study. So ENGAGE allowed to further dose reduce if they had met the criteria. And this is unique to the study versus the other ones, which if you were randomized to 20 milligram of rivaroxaban, you remained on it to the end of the study, even if you developed renal insufficiency, and same thing for apixaban. Some pharmacokinetic and pharmacodynamic differences in between those NOACs. I mean, there's some subtle but very important differences. Unlike rivaroxaban, apixaban, and edoxaban, the dabigatran is a 2A inhibitor, while the rest are factor 10A inhibitors. The CYP enzyme metabolisms is different between the 4 drugs, rivaroxaban and apixaban being the highest. Bioavailability was very high in rivaroxaban and very low in the dabigatran, and protein binding was lower in the dabigatran. And finally, renal elimination was quite high in the dabigatran and rivaroxaban. These are just the pharmacodynamic and pharmacokinetic characteristics of the drugs, versus apixaban is only 27%. That's why this drug is favored more in renal insufficiency, and there are some studies that have shown effectiveness of this. If you look at the meta-analysis of all these 4 studies, this was a great work done by Dr. Ruff and his group, you will see that the differences continues to be present, and I think it's important with these meta-analysis to kind of look at these things in a comparison, although I will have to say that there has not been, unfortunately, any head-to-head trials between the drugs, and there will not be any. So whatever we extrapolate from the meta-analysis is what we have. If you look at these pooled analysis for all studies, comparing them to warfarin, in terms of stroke and systemic embolic events, you'll see that the winner is always going to be NOAC over warfarin. However, if you see individually these drugs, you'll find out that there are some differences in those in between the 4. And in the stroke and systemic embolic event arena, dabigatran 150 had a much lower incidence of stroke compared to warfarin, and this was statistically significant, meeting almost superiority. versus and that's the same with the apixaban. As you can see, the line of the confidence interval right here and right here does not cross the line of unity, which makes this difference statistically significant. As opposed to the rocket and the engage, the line of confidence interval did cross the line of unity, number one, which tells us that the NOAC or the drug on the left side of that line of unity is better than the drug on the right by a trend, but not by statistical significance. And this is not surprising because these studies did not seek to prove superiority on the efficacy. Remember, when we talk about stroke and systemic embolic events, this is efficacy, not safety. And these studies have sought to prove a non-inferiority concept, meaning are these drugs as good as warfarin in decreasing the event rates, but not are they superior. Now, superiority was then also looked at as a secondary endpoint. After you prove the non-inferiority, then you may add, is it as superior or not? And in this studies, as we said, the RELY and the Aristol, that the rocket AFib versus the rocket engage, the Aristol and RELY were significant and superior, not just non-inferior. If you narrow it down even to ischemic stroke, the picture gets even more muddier, and you'll see that in the almost all of them, actually almost now 3 of the 4 drugs show that the non-inferiority. Again, the pooled analysis show all non-inferiority. However, but individually, they all show a trend for a lesser event rates compared in NOACs compared to warfarin. However, that's the significant. That difference was not statistically significant, unless in RELY there was some statistical significance of favoring the dabigatran over warfarin, because you can see again the confidence interval line did not cross the line of unity, which means there is not just a non-inferiority but superiority. Now, if we flip the discussion and look at safety endpoints, and now you talk about major bleeding, the picture is totally different. And you can see now that these 4 players have different impacts or different performances compared to warfarin. And if you can see in the dabigatran and the rocket, where dabigatran and rivaroxaban, the bleeding was, although maybe a trend in the dabigatran to favor NOACs, but no difference in the rivaroxaban versus warfarin. However, in the Aristol, apixaban, and engage, there was a significant lower incidence of major bleed compared to warfarin. Now, again, if you look at all 4 drugs in the pooled analysis, you'll see that the 4 of them will actually line up to be in favor of NOAC groups in general, with a heterogeneity p-value that is statistically significant. However, if you take out the heterogeneity of all 4, you'll see that these 4 drugs can be subdivided into 2 separate groups in terms of their performance of major bleeding compared to warfarin. 2 of them being equivalent or slightly better on the dabigatran arm, and the other 2 being superior, meaning significantly better than warfarin in the bleeding risk, with a statistically significant value in the apixaban and the engage. If you look at intracranial hemorrhage, all 4 drugs are winners, and you can see here that these drugs have been always significantly better performing when it comes to hemorrhagic stroke compared to warfarin, and they are all 4 are on the left side of the line of unity, and none of them cross the line of unity. So statistically significant better for all 4 NOACs compared to warfarin in the incidence of intracranial hemorrhage. Mortality has been a signal that has been looked at and has been reviewed in this meta-analysis, and also repeated meta-analysis. This is depending on which meta-analysis you read. Some of them are looking at all-cause mortality, and some of them are looking at cardiovascular mortality. And if you can see that there is a trend to better mortality in these 4 drugs compared to warfarin, but the majority of these differences are non-statistically significant. You can argue that the apixaban did not cross the line of unity, so this could be significant, although it's very close. 0.047 is almost 0.05. My analysis to this and what I get out of it is that the 4 drugs have a tendency to have better mortality compared to warfarin, but not statistically significant. So what did the ENGAGE trial teach us? This is the TIMI 48 trial. This is the landmark of the edoxaban trial. This is 21,000 patients randomized in 3 arms and a double-blind, double-dummy fashion, warfarin versus high dose of edoxaban 60 versus low dose of edoxaban 30. Now, what and who defined with a lower dose if they had a creatinine clearance of 30 to 50 or a weight less than 60 or a strong a concomitant use of a strong PGP inhibitor. These patients were followed for a mean of 2.8 years, which translated to a 60,000 patient year. And the efficacy endpoint was stroke and systemic embolic events, while the safety primary endpoint was major bleeding, defined by the International Society of Thrombosis and Hemostasis. There were 2 doses of the edoxaban used in this case. One was in the higher dose, 60 and 30, and the other dose was a lower dose, 30 and 15. And these doses, again, were reduced from 60 to 30 or 30 to 15. This is at randomization. If they had the creatinine clearance of less than 50, weight less than 60, or a concomitant medication such as strong GP inhibitor. This study, again, as earlier pointed out, has allowed another reduction of dose after randomization if these items change in those arms. And this is unique to the study because it allowed those patients to be to have their doses further adjusted if they develop a drop in the creatinine, say 2 years after randomization, and not stuck with the original dose. If you analyze the primary endpoint by on-treatment analysis, and we're going to talk about the difference terminologies of on-treatment versus intention to treat. The difference between on-treatment and intention to treat is with the on-treatment, it does take into account any crossover. So patients can cross from, in any randomized study, a patient can be crossed from arm 1 to arm 2 or arm 2 to arm 1, back and forth. If you analyze them statistically, you should discount those crossovers, and that would be an analysis called intention to treat. But if you analyze them based on treatment and you account for those crossovers, then the analysis is called on treatment. It is less statistically powerful than an intention to treat. Now, if you look at by the on-treatment trial, this means that these patients who crossed from warfarin to Coumadin to edoxaban were counted as edoxabans, and those who were then crossed from edoxaban for whatever reason to warfarin were counted as warfarin. By that analysis, the primary endpoint of stroke and systemic embolic events for the higher dose of edoxaban, 60, it met non-inferiority against warfarin by statistically significant, and it met superiority by also a statistically significant p-value. While the low dose met the non-inferiority against warfarin for these ischemic events, but did not meet superiority over these ischemic events. And it's very important to point out here that the time in therapeutic range, the TTR for warfarin was 68%. Anything above 60 is considered very important, very significant, meaning those patients 60% of the time had a therapeutic INR. In the superiority, and then you take it down to the intention to treat analysis, and here they only looked at the superiority by the intention to treat analysis, not the non-inferiority. And it was found that the superiority of the high dose of edoxaban over warfarin, the 0.017, the statistically significant superiority, was lost when you switch the analysis from on-treatment to intention to treat. So what does that mean? It means that the edoxaban high and low dose had met the non-inferiority against warfarin for ischemic events, and it met the superiority against warfarin for ischemic events only if you use the on-treatment analysis. It did not meet that superiority if you use the intention to treat analysis. And the third finding is that the The trend for lower event rates was much lower, was better in the edoxaban higher dose than the edoxaban low dose. And you can see that the further out they are, the less events they had. So higher dose had a lower event rates compared to the lower dose in comparison to warfarin. Now here is the intention to treat analysis, and then here you can see what you get. And I'm going to go back to one slide. The 0.87, sorry, the 0.08 and the 0.1. You can clearly see them here, the 0.08 and the 0.1. This is by intention to treat analysis for ischemic events, which was not statistically significant for superiority, and it did met statistical significance for non-inferiority. If you look at now the safety endpoint, now this is bleeding. And here you can see in the high dose and the low dose of edoxaban compared to warfarin, clearly there was superiority over, meaning it did not cross the line of unity, and favoring edoxaban both doses over warfarin, meaning that they had a better safety profile that is statistically significant. And here you can see the p-value of 0.001 on both the high and the low dose versus warfarin. These drugs cause less bleeding compared to warfarin. If you look at the forced plot curve, hemorrhagic stroke was way better, does not cross the line of unity, while other events, mainly either whether it's efficacy event or a combined of efficacy events or a combined efficacy and safety event, here bleeding and death, all-cause mortality, cardiovascular death, myocardial infarction, they all trended to favoritism over edoxaban, showing favoritism, a favored outcome of edoxaban over warfarin, but the hemorrhagic stroke was significantly better in the edoxaban arm versus the warfarin. And if you look at the key safety results of the bleeding, again, we're talking about bleeding, whether it's the major bleeding defined by the protocol of the International Society of Thrombosis and Hemostasis, major bleeding was less, fatal bleeding was less, intracranial bleeding was less. However, the GI bleeding was more. And this is very important. We're going to be highlighting next. Now, if you look at the net clinical outcomes, and here this is combining ischemia and death. And here you could see whatever and however mix you use, what kind of salads you put here. You take a couple of ischemic events and one safety, or a couple of safety and one ischemic. And here you'll see, again, a different combination of these net clinical events. Whenever you see net, that means it's safety and efficacy. They are all in favor of edoxaban versus warfarin with statistical significant p-value. Now remember, this trial patients were allowed to have their dose adjusted if they fell into that window of a lower creatinine. And here in this slide, very nicely, elegantly put slide, this is the forced plot curve of these individual events, and they compare them. How did they fare when you reduce the dose? Now, for let's say for stroke and systemic embolic events, it didn't change if you reduce the dose or not. The same thing for ischemic stroke, same thing for mortality. However, if you were in the major bleed and the event was almost crossing the line, meaning a little bit, meaning it meant the non-inferiority but not superior. And if you take dose reduction in consideration, you can see that they became superior in their event rates. So dose reduction does prevent further bleeding without losing a price on the ischemic events. Dose reduction does prevent better or result in better safety outcome without losing efficacy outcome. And the same thing here for the GI bleed. You can see in the GI bleed, clearly the warfarin was better than the edoxaban and the GI bleed. And this is one of the things that was highlighted in this trial. But if you then apply the dose reduction on those patients, if they met, of course, the one of those three criteria, that superiority of warfarin over edoxaban is lost in the GI bleed arena. This is again talking about this signal of cardiovascular death and mortality. A very interesting finding in the ENGAGE. Actually, there was in the high dose and in the low dose compared to warfarin, there was a trend of lower mortality. Actually, and some of those trends were statistically significant. And this was actually more highlighted later on in the trial. Actually, you can see this is days from a trial. At the 1 year mark, at the 2 year mark, they start to see the curve separate, but really separate 3 years and above. And that's where we started seeing late outcomes of favored cardiovascular mortality in the edoxaban arm versus the warfarin arm. And now, why is that? They looked at these things and they looked at the types, and they identified top 4 types of cardiovascular death. When you look at cardiovascular death, sudden cardiac death, the difference between warfarin, low dose or high dose, not much. P-value was not significant. The difference of fatal CHF, again, this is part 1 of 4 types of cardiovascular death. The difference was not much, and the p-value was not significant. And if you look at the fatal ischemic stroke, again, it's a cause of fatal cardiovascular death. Not much. But if you look at the fatal bleeding, the significance was statistically, the difference was statistically significant. So this highlights the importance relationship between bleeding and cardiovascular death. And in this study, and in this slide actually shows it even better, as you can see that here, this is just fatal death, and you can see the warfarin versus high dose and low dose. This is bleeding that caused death. They bleed, they die. Now, there are other events that were added later on that bleeding has contributed to death. Now, what's the difference between bleeding that caused death and bleeding that contributed death? Fatal bleeding is that there is no other cause for bleeding. I'm sorry, there's no other cause for death. They bled, they died. But bleeding that contributed to death, those are the people who bled, and then they stopped the warfarin, or they stopped the edoxaban, and then they had a stroke, and the stroke caused death, or so it was an indirect cause. And here you'll see that if you add up these two, whether it's direct fatal death or bleeding that caused death or bleeding that contributes to death, the p-value was statistically significant. How does that happen? Well, risk of death increased by 70% after a non-fatal major bleed. Oral anticoagulation is frequently 91% of the time is discontinued, and only half of the patients resume, and approximately 10% never take another dose. And therefore, when you don't take your anticoagulant and you have a high risk of stroke, because you have AFib, stroke then becomes a cause of death. So either directly or indirectly, bleeding is related to death. So in summary, compared to well-managed warfarin with a time in therapeutic range of 68%, once daily dose edoxaban showed non-inferiority for stroke and systemic emboli in both regimen, high dose and low dose. High dose actually showed even a lower stroke and systemic embolic events, especially when you analyze them by on treatment, and showed a trend when you analyze it by intention to treat. Both regimens significantly reduced the major bleeding, ischemic hemorrhagic stroke and hemorrhagic stroke and cardiovascular death. And finally, there was a superior net clinical outcome benefit as well. And when you say net, that means take into account safety and efficacy. Thank you very much for
Thank you so much, Dr. Firas.
For everybody, you can post your questions in the comment section, and we can get to it at the end, at the time of the discussion. Next we have Dr. Mohammed Majdi, who is a consultant electrophysiologist from Al Qasimi Hospital, and he's the head of the arrhythmia unit over there. He's very well known in the UAE and gives really good talks on all kinds of arrhythmia. So we're going to hear from him about managing a high-risk patient or difficult to manage patient, elderly with diabetes and CKD. So Dr. Mohammed Majdi, it's your floor.
Hello, hi, good evening. I would like to thank the sponsor for the invitation for this lovely meeting, and with an eminent speaker and chairperson. Today we are discussing the direct anticoagulants effect versus warfarin in a very peculiar and high-risk group, which is the elderly patient, renal patient, and of course diabetic patients. Especially, this is a main problem in the Middle East that we are facing. And when you look at some of the studies that already we have from our region, like the Gulf Safe trial, showing that most of our patients, almost 30% of them, they are diabetic. Unfortunately, they are younger than usual, and they have high incidence of stroke and comorbidities. And I would like to inform you that soon we will have the FLOW AFib trial, that it's a multi-central trial showing the demographic of the new onset AFib patient. This, I believe it will be launched soon. and published by the end of this year from the region of the Middle East and North Africa. So when we discuss this elderly patient, they are very sensitive patient. Of course, the more elderly, the more comorbidities, and we can see the risk that the patient can face. But when it comes to in comparison with warfarin, the NOACs or the direct oral anticoagulants, you can see by far they are much more safer and more in favor of the NOACs versus warfarin. Although sometimes in some medication it comes on the expense of risk of bleeding, like when it comes to the Bigetran. The Bigetran 150, we have more protection when it comes to stroke, but on the expense of higher bleeding, especially on patients who are elderly, more than 75 or 80 years old, especially when the dose of 150 milligrams. This is very important to keep in mind. On the other hand, when you have molecules like the apixaban or endoxaban, you can see you have a better safety margin in this entity of elderly group of patients with multiple comorbidities. That's why it's advised when you have an elderly patient with multiple comorbidities, you don't prescribe the Bigetran 150 because you're putting the patient at a higher risk. And when you look at the major bleeding in different NOACs and different trials, you can see whatever is encircled in red, we have more tendency to higher bleeding. On the other hand, when you look at apixaban and endoxaban, much higher safety, as you can see. And this is actually due to multiple factors, due to the renal safety, as we're going to mention later on during this presentation, and also to be on the honest side for the other molecules like rivaroxaban. When they did the Rocket AFib trial, they had a higher CHA2DS2-VASc score. So actually, the patient were more sicker and had more comorbidity in this subgroup of patients. This is the influence of age, and you can see when you have warfarin, it's incremental. So the more elderly the patient, the more risk of complication and the higher incidence of bleeding. On the other hand, when you compare this to the molecule of endoxaban, you will find that the statistic is not significant, and endoxaban is non-inferior to warfarin when it comes to this problem. And on the other hand, when it comes to intracranial hemorrhage, especially in patients who are elderly, patients about 65 or 75 of age, they are at a better, safer, and less risk of intracerebral hemorrhage in comparison to warfarin. And when we discuss renal problems, like in our hospital and Qasimi Hospital, when we did subgroup analysis, we had 30% of our patients suffer renal impairment, some sort of impairment. And almost 1/3 of this group, unfortunately, being passed into dialysis. So this is, you can see this is very important and very hectic topic when it comes to such problem. When you look at the renal elimination, which is a very sensitive issue, you will find that apixaban and endoxaban, they have the lowest renal elimination, which is very handy in patients with lower creatinine clearance and lower GFR. So this is very important to keep in mind while prescribing medication for your patients. So when you have a patient with moderate renal impairment with creatinine clearance, let's say between 30 to 50, when it comes to the stroke risk protection, you can see that all NOACs, we have a good hazard ratio for protection against stroke. Again, when we look at the bleeding risk, again, you have apixaban and you have endoxaban, you have good safety protection. Again, the Bigetran, and I'm referring to the high dose of the Bigetran, you have like a chance of bleeding with patient with moderate to severe renal impairment if you're prescribing especially the higher dose, not the reduced dose, which was studied in this subgroup of patients. And now this is a very hectic topic that everyone gets confused, because I know it's was all NOACs, but it was opened with endoxaban, and it gets confusing. That patient was high creatinine clearance. So now if you got confused for patient with lower renal function or lower creatinine clearance, what to do? You will also have a problem if you have a patient with high creatinine clearance. And you can see the effect of stroke and systemic embolization the more the increase, as you can see down on the bottom here, the more increase in the creatinine clearance, you will have a shift between warfarin and endoxifen. So warfarin becomes more or less better than endoxifen. One of the theories that was mentioned due to this, because of the rapid wash of the drug and rapid elimination of the drug. So actually it's not that much protecting. And the cutoff value is 80 milliliter per minute. And again, for major bleeding, it's not the issue. You have more protection regarding major bleeding into the warfarin, but still it's not as expected. But when you have the cumulative effect with the number intended to treat, whether you have systemic embolization or major death, and as you can see, the higher you have, the higher creatinine clearance. Again, you have like equivocal results between warfarin and endoxifen. So this is the pre-specified group, like when you have stroke patient or major bleeding patients or major bleeds and death cumulative, whether you have creatinine clearance of lower than 50 or higher than 50. Again, it favors endoxifen, as you can see. But again, if you have a creatinine clearance more than 80 or more, you should prescribe warfarin. And this is not unique to endoxifen. When you look at the Riva and apixafen, it is the same scenario and the same issue with the other NOACs. So this is not unique to endoxifen. This is with all NOAC. And I know it's confusing, especially usually as a physician, once you have a good normal creatinine clearance, you feel safe to prescribe NOAC. But when you have a super high creatinine clearance, you have to think twice, because as you can see with rivaroxaban and with apixaban, you have the same issue as well. Diabetes is a very hot topic in our region. In the Middle East, we have an incidence of 25 to 30% of our patients, they are diabetics, which is not the same like when you go to the Western countries. And this is very important because it aggravates, of course, atherosclerosis, oxidative stress, leading to thrombus formation, and unfortunately, stroke. So when you look at the subgroup of patients, whether they are diabetic or non-diabetic, all of them, they are favoring endoxifen. But it's very unique when you look at the fatal or life-threatening bleeding. It is very unique to the endoxifen. You have more than 74% or 74% hazard ratio. So this is a very important percentage of relative risk reduction, which is make it unique for diabetic patients. And regarding the protection and safety of the medication, this is, I believe when you look at this slide and you have a diabetic patient, you feel safe that this might help the patient to prevent complication and fatal mortality. And this is one of the publications looking at all 4 international trials, almost 60,000 patients, 20,000 of them, they were diabetic, and 40 or 45,000 of them without diabetes. And when you look at the analysis, again, you have very good results when you have like stroke prevention. So you have all over NOACs, you have reduction by 20% in diabetics versus warfarin. Only the beta-tran 150 significantly reduces the risk. So the beta-tran 150, we have very good results in reducing the risk of strokes, but unfortunately, this will be on the expense of major bleed, as you can see in this slide. So this is very important to keep in mind. But again, when you look here for the endoxifen 60 and 30 milligram, you have significant reducing major bleeding in patients with diabetic versus warfarin. So this is also very important to keep in mind while prescribing the medication for our patients. This is for all over the NOACs and reduction of the intracranial hemorrhage almost by 50% in diabetic versus warfarin. Endoxifen had 60% reduction, apixaban 51% reduction in intracranial hemorrhage in diabetic patients, which I think no one is prescribing warfarin, I believe, whoever is hearing me right now, and even not hearing me. Warfarin indication now, I think you agree with me, very, very, very limited indication. It's very rare now to see intracranial hemorrhage patients coming to our ER and catastrophic bleeding, which is very fortunate in our days. When you look again at the mortality, overall 10% reduction in this regardless of diabetes stage. So whether diabetic or non-diabetic, you have a 10% reduction by prescribing NOACs for our patients, which is very unique for those group of patients having NOAC in comparison to warfarin. So in summary, I would like to conclude that patient with moderate renal failure or direct anticoagulant more effective than warfarin. I think this is clear, much more safe. Only apixaban and doxaban significantly lower major bleeding. Again, this is a very hectic, and I know it's sometimes confusing, but you have to keep in mind because this applies for all NOACs. A patient with high mean clearance, the efficacy and advantage is reduced and favors warfarin. So if you have a patient with super normal creatinine clearance, you give warfarin instead of direct oral anticoagulants. And in diabetics, in comparison to warfarin, NOACs and direct oral anticoagulants, they are doing the trick. You have a reduction of stroke by 20%, reduction of mortality by 10%. Keep in mind, only indoxapan significantly lower the major bleeding by 20%, and only apixaban and doxapan lower the intracranial. This is very important take-home message to provide a more safer environment while treating patients with AFib, especially in this group of patients, elderly, diabetic, or patients. And by that, I would like to thank you so much for your attention.
Thank you, Dr. Mohamed Majdi, for your excellent talk. So we're keeping the discussions till the end. So next we have Dr. Mohamed Salah. Dr. Mohamed Salah is a very seasoned cardiologist, and we meet him always in lots of meetings with very excellent presentations. He's the head of cardiology at Kalba Hospital, and he has more than 30 years experience in the area of cardiology. So he'll be talking about a different kind of difficult to manage patients with valvular heart disease, post-TAVI, and with CAD. So the floor is yours, Dr. Mohamed.
Good evening, everybody. I'm Dr. Mohamed Salah. I am the senior cardiology consultant and the head of the cardiology unit in Kalba Hospital, MOH Sharjah, and I'm a professor of cardiology in Suez Canal University of Egypt. And I would like to thank the organizing committee and the SHAKEHEART company for inviting me to speak in this important symposium and this prestigious conference. I'm gonna to share my screen now. So my presentation today is about navigating the realm of NOAC in hard to treat patient, another group of patient or subgroups of patients that are difficult to be treated with NOAC, patient with valvular heart disease, patient with coronary artery disease, patient with bioprosthetic valve, and the patient with undergo TAVI. As we know, and you have heard, of course, from previous speakers, that atrial fibrillation is common arrhythmia worldwide, and one of the most important things that the prevalence increase stably with age. And we know from all the previous talks that, of course, the major advantage of NOAC over the vitamin K antagonist is that they are very safe and effective reduction of the incidence of stroke and systemic embolization with less incidence of bleeding. And this has been proved by all the large randomized trial. And in this, my presentation, and of course, we know that the available NOAC, we have the Bigatran, we have Rivaroxaban, Apixaban, and Edoxaban, which was being studied in the ENGAGE AFib-TIMI48 trial. I'm going to concentrate, of course, about the ENGAGE AFib-TIMI48 trial. And the first group of patients that I'm going to show it to you is the patient with coronary artery disease. And as we know, in this the trial, subgroup of patients, 4,500 patients with prior coronary artery disease, showed that edoxaban efficacy even better in patient if we look to the patient with coronary artery disease with greater reduction of ischemic event in comparison to warfarin. What about safety? As we can see that edoxaban safety is not affected by coronary artery disease as it's associated with less incidence of bleeding, either major bleeding or intracranial hemorrhage in comparison to warfarin. Then, if we look to the coronary artery disease NOAC meta-analysis, this is very nice meta-analysis, which showed clearly that the NOACs are superior in reduction of stroke and systemic embolization in comparison to warfarin. However, edoxaban showed more than, in addition, 35% risk reduction of the incidence of stroke on top of other NOAC. What about the safety-wise or major bleeding? As we can see, all the NOACs, they have less incidence of bleeding in comparison to warfarin, and edoxaban show on top of the other NOAC more than or 19% more risk reduction in the incidence of major bleeding. What about the cardiovascular death, which is a very important point, as we know that atrial fibrillation is a vascular disease. And as we can see, all the NOACs are associated with less incidence of cardiovascular death in comparison to warfarin, and edoxaban show more than or more on top of them 31% more risk reduction of cardiovascular death on top of other NOAC. This is a very nice meta-analysis which compare of the NOAC atrial fibrillation and BCA trial. And as we can see, the incidence of bleeding is very less in patient with in the patient who received NOAC in comparison to vitamin K antagonist or warfarin, despite that the favor NOAC in dual antiplatelet therapy in comparison to warfarin and triple antiplatelet therapy. This has been clearly demonstrated in all the AFib trial, Augustus trial, Entrust AV BCI trial, Pioneer trial, Redual BCI trial. That's why, if you look to the latest guideline for HRA, practical for NOAC and anticoagulation post BCI and acute coronary syndrome, they all insisted, and either in patient with elective BCI or patient with undergo acute coronary syndrome with BCI, you have to start with the triple therapy for 1 week, which is a very brand new, and or up to 1 month. Then after that, you have to shift it to the dual therapy, either NOAC plus, of course, clopidogrel. Then after 6 months, you have the chance to either for acute coronary syndrome BCI, you have to stay with dual therapy, NOAC plus clopidogrel, or after an elective BCI, you can stay with NOAC. But however, and after 1 year, you have to stay on only monotherapy with NOAC. Then the second group of patients, we have patients with valvular heart disease. And as we know, NOAC, as you clearly demonstrated here before, is contraindicated in patients with prosthetic valve and patients with severe rheumatic mitral stenosis. Apart from this, you can give NOAC to any other patient with valvular heart disease. So that's why in ENGAGE AFib-TIMI48 trial, they studied subgroup of patients with valvular heart disease. Patient who has history of valvular heart disease or baseline echo evidence of left side valve lesion. Moderate to severe aortic regurg or mitral regurg, patient with moderate to severe aortic stenosis, patient has prior valve surgery by prosthetic valve repair or valvuloplasty. In this trial, we have 20,000 patients were randomized to non-valvular heart disease and valvular heart disease. The group of valvular heart disease, about 3,000 patients. Patients were randomized, as we know, in this group either to warfarin and edoxaban in a very high dose, 60 milligram, or edoxaban low dose 30 milligram. By the way, the FDA approval dose is the edoxaban 60 milligram. And this is the regimen approved by FDA for patient used in AFib. Then, what about we have to look by efficacy and safety. If we look to the subgroup analysis, we can find that the edoxaban show as a benefit a reduction of stroke or systemic embolization in subgroup patient with valvular heart disease in comparison to patient with no valvular heart disease. They are both show reduction in the incidence of stroke or systemic embolization. They are effective, but the reduction was more pronounced or appear more clearly in patient with valvular heart disease. What about the bleeding tendency? There is a reduction of the bleeding tendency on both groups, but the reduction is significant more in patient with valvular heart disease in comparison to patient non-valvular heart disease. And as we can see, there is early separation of the curve. This means that the safety is very high for edoxaban patient with valvular heart disease on higher dose edoxaban regimen, 60 milligram. Then what we have another subgroup of patient with a bioprosthetic valve. This is the subgroup analysis, as we know, edoxaban for the prevention of thromboembolism in patient with bioprosthetic valve and engaged AFib TIMI 48 trial. Look at this, the outcome. The outcome in patient with bioprosthetic valve randomized to either edoxaban versus warfarin. And here again, we use the high dose edoxaban or lower dose edoxaban versus warfarin. And they will look to the primary endpoint. 191 patients with left-sided bioprosthetic valve, 131, 69 mitral position, 63, 31 in aortic position. Then, what about the primary endpoint? If we look to the stroke or systemic embolization event, as we can see, edoxaban in both doses, either higher dose or lower dose, so significant reduction in the incidence of stroke or systemic embolization in comparison to warfarin, and diseases persist up to 3 years. Then, what about safety-wise? The major bleeding, either also edoxaban in a very high dose or lower dose, so major reduction in the incidence of bleeding in comparison to warfarin. If we look to the primary net clinical outcome, we can find that there is also in favor of edoxaban in both doses in comparison to warfarin. Mind you, that we use the, and as a conclusion come from this trial that compared with warfarin, higher dose edoxaban had similar rate of reduction of systemic embolization and stroke and the major bleeding in patient with bioprosthetic valve. There was no evidence of effective modification by the presence of bioprosthetic valve for systemic embolization or major bleeding or stroke. But for the net clinical outcome, the effect of higher dose edoxaban versus warfarin was greater in what? In patient with bioprosthetic valve when compared to the effect in patient without bioprosthetic valve. And the effect of higher dose edoxaban versus warfarin in the net clinical outcome in patient with bioprosthetic valve, as we saw before, was also greater than in patient with valvular heart disease but no bioprosthetic valve. Absolute event rate among patients with bioprosthetic valve were very low. See, this is a very encouraging data from in the patients with bioprosthetic valve. Mind you, this is group of patients that we are seeing commonly in our practice, but there was no before available data about how can we deal with this group of patients. Then let us go to the final group of patients, is patient with TAVI, and patient undergo TAVI. And as we can see, this is come from Envisage TAVI AFib trial. This study was published in the New England Journal of Medicine and has been published or been exposed in the latest European Society of Cardiology Congress 2021, edoxaban versus vitamin K antagonist for atrial fibrillation after TAVI. The background, approximately 33% of patients post-TAVI present with prevalent or incidence of atrial fibrillation. However, the evidence of for various antithrombotic strategy for AFib after TAVI is typically still not yet fully studied, and the need to conduct this sufficiently powered randomized control trial to investigate the efficacy and safety of NOAC based on a vitamin K-based oral anticoagulant approach in TAVI patient with AFib. Edoxaban was non-inferior, as we know, to vitamin K antagonists in the prevention of stroke and other thromboembolic event, with lower rate of bleeding and the cardiovascular death in general population of atrial fibrillation at moderate at high risk of moderate to high thromboembolic risk. This has been proved, and it was nicely, clearly demonstrated in the randomized trial. So the objective of this trial is to compare the efficacy and safety of edoxaban versus vitamin K antagonist in patient who has prevalent or an incident atrial fibrillation and they have an indication for chronic oral anticoagulation therapy and after successful therapy. The primary efficacy outcome is called NACE. That's what we all call this: myocardial infarction, ischemic stroke, systemic thromboembolic event, valvus thrombosis, and the International Society of Thrombosis and Hemostasis bleeding. This is the efficacy outcome. The primary safety outcome, International Society of Thrombosis and Hemostasis define major bleeding. So we have a very good, the primary endpoint is very strong point, also the safety outcome. Then, this is the study design. As we said, it's prospective randomized open-label blind evaluation of edoxaban-based regimen versus vitamin K antagonist. Patient undergo TAVI who severe complication, with or without severe complication at randomization. They are randomized to either from the evening of TAVI up to 5 days. Either you can start from the evening of TAVI directly up to 5 days or up to 7 days for permanent pacemaker. Patient were randomized to edoxaban 60 milligram per day with or without antiplatelet therapy versus vitamin K antagonist with or without antiplatelet therapy. This is very important. Edoxaban dose reduction to 30 milligram, where when we use it for atrial fibrillation patient, if they have creatinine clearance around from 15 to less than 50 and the body weight less than 60 per kg. Vitamin K antagonist patient, the target INR should be 2 to 3. And then the antiplatelet therapy was allowed for the allowed per treating physician according to his need, including either dual antiplatelet therapy up to 3 months or single antiplatelet therapy life-lasting or long time. Then, if you look to the NACE, the ischemic stroke and all-cause death, as we can see that there is significant reduction of the in favor of the incidence of ischemic stroke in favor of edoxaban in comparison to vitamin K antagonist. And this reduction appears from early day or even from the first day of post-procedure. Again, for all-cause death, there is reduction of all-cause death in favor of edoxaban in comparison to vitamin K antagonist. What about the primary efficacy outcome and component? As we can see, the primary efficacy outcome, there is the reduction of stroke in favor of edoxaban, better in comparison to warfarin. However, the major bleeding is more in vitamin K antagonist arm, is more in edoxaban arm in comparison to vitamin K antagonist arm, and the bleeding measure of this bleeding was GIT bleeding. Okay, what about dose adjustment criteria? Is there any difference if we have an edoxaban higher dose or edoxaban lower dose, 30 milligram? And we know now, again, the 30 milligram for atrial fibrillation used in patient with creatinine clearance less than 50, creatinine clearance between 15 less than 50, and the body weight less than 60 kg. And as we can see, there is no there is this reduction of the ischemic stroke and the reduction of intracranial hemorrhage in favor of edoxaban, either in higher or lower, without no effect on the dose adjustment. However, still the major GIT bleeding are more in the edoxaban arm. What about if you use the outcome by specified oral anticoagulant? It makes no it makes difference? No. We can find still we have a very nice reduction of the primary endpoint in the form of reduction of ischemic stroke and intracranial hemorrhage in favor of edoxaban arm in comparison to warfarin arm, but still the major GIT bleeding occur in the less in the vitamin K antagonist arm. So this is the result overview. As we can see, there is non-inferiority criteria met for NACE as the primary endpoint. Higher rate of major bleeding with edoxaban were driven by major GI bleeding, and we found that one major GI bleed was fatal in the edoxaban arm. The rate of intracranial hemorrhage or fatal bleeding were similarly rare in both trial arms. Patients who fulfilled the dose adjustment criteria and received edoxaban 30 mg had similar MACE and the major bleeding rate as compared to patients with vitamin K antagonists. Among patients with pre-specified antiplatelet therapy, edoxaban was associated with higher rate of major bleeding when compared with vitamin K antagonists. The conclusion from this trial in envisaged TAVI AFib in patients with indication for oral anticoagulation after successful TAVI, edoxaban was non-inferior to vitamin K antagonist for the composite or the primary composite outcome of adverse clinical event. In this patient, edoxaban was associated with higher major bleeding risk in the overall population, especially GIT bleeding. Sub-analysis suggests that patient fulfilling those adjustment criteria and the patient without concomitant oral antiplatelet therapy may be reasonable or appropriate candidate for edoxaban based on attenuating bleeding difference versus control. However, of course, this is just preliminary data. We need further investigation into these topics, and I think there is so many studies on the way. If you look to the comparison of the 3 DUAC trial in TAVI, envisaged for edoxaban, Atlantis for edoxaban, Galileo for rivaroxaban, we can see that the incidence of stroke is less in envisaged arm edoxaban in comparison to what we have it in Atlantis and Galileo arm. Also, but the bleeding is higher, as we know, in envisaged and Galileo with less incidence in Atlantis. So, in summary and in my conclusion, novel oral anticoagulant offer benefit for patients with atrial fibrillation and the VTE. They are as safe as and probably safer than warfarin, low risk of intracranial bleeding than with warfarin, low risk for major bleeding for some novel anticoagulant. Trial data and real-world experience accumulating, net clinical outcome to balance benefit with risk in long-term anticoagulation. Novel anticoagulation should be seriously considered for prevention of thrombosis, and we can say that edoxaban is one of the important NOAC that can be used in a very high risk group of patients, as we mentioned, patients with valvular heart disease or coronary artery disease, and the TAVI patients without prosthetic valve. And as we see that, we have a good or encouraging result in all these group of patients. Finally, thank you so much for your attention.
Thank you so much, Dr. Mohammed Salah. And I'd like to thank all the speakers that are with us right now. I think you all raised very important and very debatable points. So I think it's very important that we take the endpoint of everybody that's here, Dr. Mittal, Dr. Mohammed Majdi, and Dr. Salah, and all the questions, because I think there is a lot of variation in terms of practice, and especially in these, high-risk patients. So maybe let's talk a little bit about the TAVI patients. Dr. Mohammed Salah, you gave us this study, and you showed us all the other studies as well with the other NOACs. So in your practice, what are you going to do if you have a TAVI patient who developed atrial fibrillation? What's your go-to therapy?
Thank you, Dr. Ajwareya, for this nice question, and I would like to thank Dr. Brajesh for inviting me in this prestigious conference. As I showed that the result still not fully met our expectation. The patient undergo TAVI, and still we have some complication like the GIT bleeding. But in my opinion, if I have a patient like that with TAVI and have atrial fibrillation, I think I'm gonna to start him with DUAC, and maybe I will start with edoxaban. But I have to be careful about of course, what we have, the GIT bleeding. And despite that, it was only one case that it has major GIT bleed. But anyway, safety-wise and efficacy-wise, it should have good result. So I will go for edoxaban for this patient.
What do you think, Dr. Mohammed Majdi?
Yeah, if I may add, I agree with Dr. Mohammed Salah, but I think the first thing we should assess the bleeding risk scoring system. And we should keep something in mind, because this is usually missed. When you have a has bled score of 5, this means that the patient is at risk of bleeding more than 10 or 12%.
Yes.
And this doesn't mean that the patient is at risk of 10 to 12%. It's more than 10 or 12%. So actually during the having the scoring system for the HAS-BLED score, which is very unique, they stopped at that level. Can you imagine? So they stopped at that level and they said it's more. Maybe it's 20, maybe it's 30, maybe it's 40, but it's in our hand. So when you have a geriatric patient above 80 or 90 with a TAVI, and he has a previous PCI, and he's on dual antiplatelet, and he's taking anticoagulant, and he has a GI bleeding, and his blood score is 5, I think his bleeding risk is more than 30 or 40% actually. So I think this is a group of patients that we have to risk stratify case by case. And some of those patients, we might even think about appendage occlusion in this category of patient. I'm not talking all TAVI patients. I want to make it clear. Very, very high risk of patients of bleeding, we might consider appendage occlusion. And anyway, they are taking antiplatelets. And now with the new devices that we are implanting, we don't need to give anticoagulation. We give a single antiplatelet for 1 year. And even if the antiplatelet is not indicated, we don't need to carry on with the antiplatelet. So I think this might be one of the ways to secure our patient, and we can run away of bleeding. We are not doing appendage occlusion as before. Two things we are not doing as before. One of them is appendage occlusion, because alhamdulillah, the rate of bleeding is much, much, much less. I remember 2014, 2015, even up to 2016, we were using warfarin during that time. We were doing maybe 12 to 15 cases appendage occlusion per year. Can you imagine, Dr. Ajware and everyone? We are doing now 3 to 4 per year. This is the maximum number we are doing in high-risk patients. And I think this is thankful to the industry and to the medication that we are having right now, because this is one of the heartbreaking events that we can see in our ER. Patient with massive cerebral bleed, because actually we look at the patient and we don't know what to do for this patient. So this is my point. I hope it's helpful. Thank you.
No, and I agree totally, 100% with Dr. Muhammad, because if I have a really patient with HAS-BLED score, of course, he's my referral. I'll send this patient to him to make this left atrial appendage closure. He knows that, and especially in our region, that we have younger patients, or 100 or more over in our region. So, of course, HAS-BLED score should be considered, should be calculated, and then after that, you take a decision. Anyway, and I'm speaking about the patient if this HAS-BLED is not high. And sometimes patient, when we are telling them that, okay, I will give you medication, but I will refer you to make some procedures that will protect you, but you'll find them, they will a little bit reluctant or, afraid. So at that time, you have the choice to do the WAC, especially doxaban, provided that, as Dr. Muhammad said, the HAS-BLED score is not high.
Dr. Mittal, do you have any comment on the?
Yes. Yeah, so it's we always have to balance bleeding versus clotting. This is a fundamental rule. And now we have some good DOACs, which we're using for almost a decade now. And there's improvisation. We started with the Predexa, what we call dabigatran, twice a day, and then 2 different types of doses and all those. And clearly we have the superior agents. I will rather put a counter question, that where and how will you differentiate between the 3 available out of 4? We put aside the dabigatran for the moment. So the later 3 agents, is there anything particular preference for one over the other in any particular situation? Do you have any such data or any such recommendation from any of the societies or based on the studies?
Again, it depends, like case by case, of course, because and this is, I think, what's unique, because we have different varieties. Like, for instance, the renal elimination on one NOAC, the reduced dose in the other NOAC. So it depends on the patient criteria. You can choose the ideal NOAC. Like, for instance, if you have a patient with a GIT, we'll put Paradexa aside, as you mentioned. We will compare the other 3 NOACs. If you have a patient who has a GIT problem, and he's known for having a GIT problem, frequent dyspepsia, and he's always complaining of this, I will not think about rivaroxaban, for instance, as my first option or as a first choice. On the other hand, if I have a patient who has like diabetic retinopathy and severe eye bleeds or recurrent eye bleeds, again, I will take aside apixaban out of the question because they have more tendency of eye bleeds in those category of patients. When you have a patient on dialysis, and I would like to quote this because it's a little bit again confusing in the American guidelines. It was mentioned that if you have a patient who is a renal patient on dialysis, you may consider using apixaban, and they mentioned apixaban. When you go to analysis of this trial, actually this trial was subgroup analysis done on only 8 patients. And personally, I used it with caution, this group of patients, and we had not major bleeds. We had some element of minor bleeds like gum bleeds and some of the problems that might be alarming in those patients. So when you have a patient on dialysis, this is a very hectic case. Believe me, this is the worst case to be discussed. It's not the TAVI, it's not the atrial fibrillation, it's not the elderly, it's not the diabetic, it's the renal dialysis patient. This is the most crucial, tough decision making, which NOAC to use and what is the dose to use. And you don't have guarantee with any of the NOACs, especially most of the trials that was coming, randomized control trials, some of them, they were put on hold. We have some trials not randomized, promising, showing that we might have some good results. But again, I don't feel confident as a physician when I have a patient with dialysis comorbidities, especially if he's on antiplatelets as well, or of prescribing NOAC for this group of patients. So going back again, it's a case by case, and you have to think about it. Like if you have a patient with PCI, and this patient has atrial fibrillation and he's on antiplatelets. Again, this is one of the scenarios that you have to think about which NOAC you're going to use. For me, like if I have an elderly patient who's like 80 or above 80-year-old, and he's taking dual antiplatelet and he had recent stenting, I would like to go more with the trials that tested the reduced dose, like the Redual trial, when they used the 110 milligram, because actually there is a trial used a reduced dose. The 2.5 apixaban and the 15 milligram rivaroxaban, actually this was deducted from the original trial. It was not a unique trial with a reduced dose. But when you have endoxapan 30 milligram, you have a unique trial, which is very good. And when you have the Redual trial, you have the 110 from the Relay trial, 110 milligrams. So I think this will be like, if I am facing this category of patient, I will think with these 2 medication. And this what makes it unique. 75 of our cases, they are straightforward AFib patient, but still we have 25% of our patient that we have to discuss. And in the morning meeting, we usually discuss this 25% of patients, and we open this discussion that we are opening right now to like brainstorm what is the ideal NOAC for this subcategory. And thank God that they are only 25%.
So there is an additional question related to this. That suppose you have to do switching, and I'll be very straightforward. I had a patient was on apixaban twice a day. So that patient compliance was poor. So then I thought I will change him to edoxaban. So what is the principle of switching? Is there any particular criteria of switching from apixaban twice to edoxaban once?
What is the reason for switching again?
Poor compliance. He was not willing to take twice.
Compliance.
Yeah, compliance was poor. He didn't want twice a day daily dosing of apixaban, so I thought I'll put him on a single day dose of edoxaban. So is there any particular principle which you will apply practically?
If you have a patient on dual, like taking 2 tablets BID per day, you have to skip 1 dose, then you can start with the 1 dose regimen. Just skip 1 dose and you can go ahead with the dose regimen. It's never more or less hectic when you are switching between NOACs. It will be only hectic if you are switching between warfarin and NOAC and vice versa. This will be a little bit more hectic because you have to think about the bridging or giving anticoagulants, or you have to monitor the INR. And this is very limited cases. And I will tell you one of the cases that I think this is the only case that you have to think about it when you can switch from NOAC to warfarin, right? This seems like quite awkward, right? But let's say you have a patient who came and he was just starting NOAC, and you wanted to cardiovert the patient, and you did TE for the patient, and you find a thrombus. Still in the guidelines, if you're fighting thrombus in the left atrium, it's warfarin. It's not
Yes.
NOAC. So this means you have to switch the patient from NOAC to warfarin. So here it depends on the type of NOAC. Sometimes it gets a little bit hectic, but again, it might take like 2 or 3 days, but it's doable as well.
I think the advantage of a single dose is the compliance, and which is very important to our patient, really. Especially in our region, that you know that most of our patient in the Northern Emirate, you find that they are 80 plus, or as I told you, 100 plus. So they will come to complain to you. Even their family members, they told us that we don't like this one, he doesn't like to take it. So the single, I think, thanks God that we have different varieties of NOAC, and we have the chance to choose whatever you like according to the situation of your patient. So according to the protoplasm of your patient, then you can choose the suitable NOAC for this patient. So I always go with a single dose NOAC, because this is it will be much easier for our patient.
Yeah, like if I have a straightforward case of atrial fibrillation, for instance, and this patient is on antiarrhythmic drug and will be only on antiarrhythmic drug and NOAC, I can go with any one of them, because this will not be very hectic for the patient. But if I am treating AFib patient in a heart failure patient, and you can imagine by heart failure, diabetic, hypertensive heart failure patient, he's taking maybe like at least 7 to 8 drugs medication, I will consider using a single oral dose for those patients. So again, it's case by case.
Dr. Mohamed Majdi, we go back to the dialysis patients, the headache patients. So, I mean, if you're stuck, like if you try the DOACs and you have a lot of bleeding, isn't that an ideal patient for LA appendage closure? Especially that LA appendage closure is equal to warfarin. We know that. We don't know how.
Yeah, it's 2B in the guidelines. And thank you for asking this question, because this question is very crucial nowadays, especially in the UAE, guys. Because now the UAE is moving towards renal transplant. And one of the criteria for assessing candidates for renal transplants is the risk factor and the bleeding risk scoring. So having a patient who's going for renal transplant and he's on warfarin, this increases his risk of bleeding during the procedure, and actually can eliminate him from the transplant list. So those group of patients, once you put appendage occlusion, and I do have a patient of mine, we did, because he had several attacks of bleeding on warfarin, we did appendage occlusion for this patient, and he never experienced a single attack of bleeding or stroke, and he underwent renal transplant as well. So those entity of patients, once they experience an attack of bleeding, or they have very high Has-Bled score above 4 or 5, we should consider appendage occlusion for them even before they actually bled.
Yeah, it's a very good example and very good practical application. So
yes,
right, very good. So my last question from my side, and discussion for everybody's sake: are you very concerned about high GFR, and do you absolutely not use edoxaban?
Yeah, this was in my presentation. And we are talking about renal patient, dialysis patient, low GFR, and now we have high GFR patient. And actually, in my hospital, we had a case, a patient with a very high GFR. It was like 95, and my colleague, he prescribed for him warfarin, because he cannot prescribe NOAC, and the patient had retroperitoneal hematoma and psoas muscle bleeding. So you can see it gets very hectic. And as I mentioned in my presentation, this is an all NOACs. It was just labeled with the endoxaban, but actually it follows all the NOACs. I think it's related to the elimination process, one of the things. And studies showed that warfarin as a protection is more superior to NOAC. So I think we still, once we face this issue, we will give warfarin for safety, But again, this will be on the expense of bleeding. But let me tell you something. If I have a patient with multiple comorbidities and he has a high GFR, which I doubt with comorbidities to have a high GFR, but if this happened and this patient has blood score is very high, 4 or 5, and he has high GFR, I might consider appendage occlusion for this patient, because I'm a not believer in warfarin. I'm very worried with warfarin.
Yeah.
Believe me, when I have a patient with warfarin, I am very worried sick, especially in elderly patient with comorbidity, renal patient. I worry sick. When they come to my clinic, like if a patient with a valve, for example, like mitral valve replacement, and the patient is on warfarin, and I did a procedure like atrial flutter ablation for those patients. When they come to the clinic, I'm very worried, and it's quite often when we do the follow-up INR for this group of patients, we find like 4, 5. It's related, as you know, to meals, to food. It's very labile. So I have to admit, I don't like warfarin. I'm afraid from warfarin. So whenever there is worries,
I don't like warfarin at all. And if I have the chance to get rid of warfarin, yes, I will. Of course, I will escape from warfarin.
Yeah, because for me, I don't have the slides right now. If I shared with you some of the images from 2000, maybe 2005 up to 2014 or 15, it's heartbreaking, the amount of cerebral bleeds that I saw in my life being managing patient with atrial fibrillation. And actually, some of the patient, I can say roughly 25 to 30%, they died. Actually, they didn't carry on with the hospital course, and the remaining patients, they were completely bedridden, and eventually they died as well. And you face lots of problems that you cannot help those patients. But since we are starting using NOACs, this is very, very, very minimal. And I will tell you something. In my hospital, we have reversible agent. We never used it.
You never use it, yes.
We never used it. So this is a good example as well, that the bleeding that even that we are facing, it's not severe. Maybe some patients who are prone had like some element of minor GI bleeds. And once we calculate the has blood score for them, if it's high, we can consider appendage occlusion. But if it's very minimal, we can just follow up them or switch to another NOAC, as you did with your patient, to another NOAC, which is not like more susceptible to GI bleed, and follow up of those patients.
But I think the issue with the very high GFR is not that common in clinical practice. Like, we don't see it that common. I don't know.
Our patients are diabetic, Dr. Ajwairia. For almost 40%, they are diabetics. We are not. Maybe this is in Europe,
Yeah, exactly.
Yeah.
When I was in
France, every time I see a diabetic patient, I was surprised, because it's very rare to see a diabetic patient there. But our patients, they are diabetic, they are hypertensive. When you look at the Gulf SAFE trial that I mentioned in my presentation, our patients, they are younger and more comorbid. Can you imagine? Like in Europe,
yes,
the patients, they are like 70 plus. In our region, they are 50 plus with the same comorbidity of the 70 plus. So our patients, they are younger with comorbid. So that's why we are facing it a lot. It's I'm not sure that this is for our luck or for our patient. I'm not sure, but let's hope for the best, inshallah.
Yeah, inshallah.
Great.
So I think we covered lots of very good, important topics. Maybe we'll get a final comment from each speaker, and then we can close the session. So, Dr. Muhammad Salah, what's let's say the key taking point from your talk?
Key taking point.
Yeah, the key point is that we have always to consider NOAC. We have to have a brave heart. Don't be afraid to prescribe NOAC, but usually take in considerations that you have to make risk stratification for your patient for the bleeding, and you have to calculate the benefit risk ratio of the bleeding versus stroke. But in general, I recommend you to use most of our patients to put them on NOAC, because they are very safe and effective with less incidence of bleeding, and stay away from warfarin as much as you can.
And Dr. Mohammed Majdi?
Again, as I mentioned, 75% of our cases, they are straightforward cases, and the 4 molecules that's available, all of them, they are very good. When you have a patient who's low risk, you don't have to worry about anything. Prescribe any of them. It should not have any problem. It's only 25% of our cases, like patients with TAVI, patient with renal dialysis, patient with renal impairment, patient with dual antiplatelets and recent PCI. Those the group of patients that we have to discuss. And I believe, and my advice, this is my personal experience and my advice, it's very nice to discuss this. Don't take the decision just by your own self. It's very nice in the morning discussion with the team, with the other consultant, to present the case, which is very unique, and discuss and brainstorm. Someone will say something that maybe that you missed in your mind, and you can share the decision together to come with the ideal NOAC for your special patient. Thank you.
Thank you. Dr. Mittal, do you have any final summaries you would like to add?
I have only a dream that someday the NOACs are available for prosthetic valve also, metallic prosthesis. So that's the only last area where we still have to struggle with warfarin. So we are waiting for the development in this area. But NOACs
But
and
what's
DOACs
good,
will be
Dr.
normalized
Mittal,
much.
that they are having valves coming now. One of them, they started with the aortic valve, which is tissue valve, up to 30 years without anticoagulants.
Correct.
So I think they're also working on the mechanics of the valves as well, which is good as well. I'm promising.
Yes. So hopefully at one time we would not
you.
have any mechanical valves. We'll
Absolutely.
only with bioprosthetic valves, and we can use wax on everybody. So I'd like to thank you all for joining this session. It was very interesting and very practical, and I enjoyed your talks very much. And I think we're ready to close this session, and I hope you enjoy the rest of the meeting with Dr. Mittal. He has done a wonderful job with this Congress, so I wish you all enjoy this meeting.
Thank you.
Thank you so much for all coming over. And
thank you, Dr. Rajwari,
nice
for
meeting
this
you.
comment. Good luck.
Thank
Very
you.
nice meeting. Have a nice night.
Thank you. Thank you. Thank you. Good evening.
Thank you. Bye.
Thank you. Bye. Welcome back. We are heading for the last session of the day, and this session is also quite going to be an exciting, short and crisp 3 lectures of cardiology in daily practice. So we have the moderators listed: Dr. Praveen Chandra, Dr. Rajiv Gupta, Dr. Tamkin Kena, and invited moderator, guest moderator, Dr. Pradeep Gupta. So I invite our moderators to join and take on the proceedings for this particular session. Thank you.
Good evening, Dr. Rajiv Gupta.
Hello, dear. How are you?
Fine, fine.
Nice to see you after quite some time.
After a long time.
In fact, I was thrilled to attend the conference because I will love to hear you and to see you. That was my flavor.
Right.
Yes, so I think we can start with the first lecture, which will be from Dr. Khanna. So, Dr. Gupta, for your information, there was a swapping of the lectures between Dr. Gupta and Dr. Khanna. So, Dr. Gupta's talk has already been done, and now it will be Dr. Khanna's talk. Yeah.
Good.
So,
yes,
Dr. Rajiv Gupta, you can start the first one.
Yes, Dr. N.N. Khanna.
Yes. So,
Dr. N.N. Khanna, I am glad to introduce Dr. N.N. Khanna to the August gathering. And Dr. N.N. Khanna is not a new figure in cardiology, not only in India, but in UAE also, because he has been with us earlier in the conferences and he has huge experience in cardiology, both in non-invasive and invasive cardiology in focus. And he works in the prestigious Apollo Indraprasth Hospital at New Delhi. In addition to his clinical liability, he is quite actively involved in the academics and the registries and writing papers and presenting many in the many conferences and the meetings. And without taking much time, I invite Dr. N.N. Khanna to present his talk.
thank you.
Good evening to all of you. I thank Dr. Brajesh for inviting me to this wonderful meeting, the SHAKEHEART 2022. Actually, I'm called for an emergency case. I may not be able to join, so I'm recording my presentation. The title of the presentation is Immediate and Long-Term Management of VTE and Pulmonary Embolism. And in the next 15 minutes, I'm going to take you to the risk factors, the immediate goals and the long-term goals, and the management for VTE and pulmonary embolism. Now, just to put things in the right perspective, VTE actually encompasses acute deep vein thrombosis, which is DVT, and pulmonary embolism. And together, they are known as VTE. Now, the risk factors could be idiopathic, or the presentation could be just primary DVT, which increases with age, and also with association of cancer, residual thrombus from previous DVT, male gender, and genetic tendencies of thrombophilia actually account for high incidence of DVT in a particular cohort of patients. It is the leading cause of death worldwide, and it is estimated that there are more than 500,000 deaths every year in Europe because of VTE alone, and an estimated 3 lakhs VTE-related deaths in US every year. It's estimated to cause at least 3 million deaths a year worldwide, and this is the map you can see worldwide. We have a small study from CMC Vellore in India. This was done from 1996 to 2005. And the incidence of VTE was 17.46 per 10,000 admissions. And among the risk factors, malignancy accounted for 31% and was the most common predisposing factor, followed by post-operative status. The incidence following surgery was 5 per 10,000 operations and was highest. General surgery patients had the highest incidence of deep vein thrombosis, while the incidence in orthopedic patients was about 20.1%. Pulmonary embolism was diagnosed in 14.9% of the study population, and the mortality in those with confirmed pulmonary embolism was 13.5%. VTE is no longer a rarity in India, and it continues to be suspected more often than it is diagnosed, and it is prudent to actually have a very high index of suspicion and to treat them as and when required, proactively than counteractively. Now, coming on to the specific goals of VTE, the specific goals are prevention of embolization to the lung, prevention of extension to larger veins, that means the proximal extension, then to prevent recurrence and avoid complications of DVT. Now, in VTE, the conventional anticoagulation treatment was the treatment, and it involves treatment of acute phase, recurrent prevention, and extended use, and I'm going to be discussing about it in the future slides. Initially, the treatment would be heparin or low molecular weight heparin for at least 5 days, followed by oral anticoagulation, which could be vitamin K antagonist maintaining an INR of 2 to 3, or extended use of VKA and maintaining the same INR of 2 to 3 for three months to indefinitely. Now, in this acute phase, recurrent prevention, and extended phase, now we also have a wonderful group of drugs called the NOACs, and I'm going to be subsequently telling you about this. VKA alone takes too long to provide VTE, to provide anticoagulation in VTE patients. That is why initially it's prudent to use heparin or low molecular weight heparin for 2 to 4 days. And after this, we convert them to VKA therapy or NOAC therapy. In 2014, the ESC-PE guidelines actually had a class 1 recommendation for PE, unprovoked PE, treating them with heparin and anticoagulation for at least 3 months. And also for NOACs, which could be either rivaroxaban, apixaban, or dabigatran, and also endoxan for treatment in the initial phase. All of them had a class of recommendation, which was 1, and level of evidence, which was B. Now, in 2016, ACCP guidelines for VT antithrombotic therapy, initial anticoagulation was again preferred, and it has class 1 and class 2 recommendation, as was the same with ESC 2019 guidelines. So there is no question that anticoagulation remains the mainstay of treatment in VTE in acute stage. And there are different drugs. We have vitamin K antagonist, and we have NOACs, and in NOACs we have these 4 drugs. I'm not going to be going to the pharmacology of these NOACs, but we know that they're all very safe drugs, and apixaban actually has the lowest major bleeding complication. Now, in patients where we actually want to prevent post-thrombotic complications, or where the risk of pulmonary embolism is high, or if there is a pulmonary embolism with cardiogenic shock, or the VTE happens despite oral anticoagulation therapy, it is much prudent to have an early clot removal by thrombectomy or thrombolysis. And this has now become a higher class of treatment in patients with acute DVT. It prevents post-thrombotic syndrome, and a catheter-directed thrombolysis for deep vein thrombosis was studied in KEVIN trial, and it has a follow-up of 5 years. It was an open-label randomized controlled trial. Now, there could be an endovascular treatment, which is now mostly restricted to specialized to pharmacoinvasive therapy, where we isolate a segment of thrombus and then do a lysis and do a thrombectomy for the same. Now, pharmacomechanical catheter-based thrombolysis, we have different dedicated devices. I'm not going to go to the detail of these specific devices, but the concept is that you isolate a segment of the thrombus, acute thrombus, and then lyse this or pulverize it, and then take out this thrombus from the vein segment by segment. This works very well, and it leads to a rapid thrombus removal in acute patients of DVT. And this leads to prevention of valvular function, preservation of valvular function, and also preventing post-thrombotic syndrome. Now, a little talk about IVC filters. They are contraindicated in patients where there is, where the patients have infection and the compliance is poor, but it is indicated only in patients where anticoagulation has failed, or there is a very high risk of acute pulmonary embolism because of proximal or proximal IVC, ilex or proximal IVC thrombus. And there is no doubt that now the IVC filters have to be put. They should be put only temporarily and should be taken out as early as possible because of the concomitant complications, which could be thrombus formation itself or gut perforation or IVC perforation. Now, this is very important, and where it should be used, the thrombolytic therapy or thrombectomy therapy should be used in proximal DVT, not distal DVT, and IVC filter should be used in proximal IVC DVTs, and should be taken out as early as possible. So I'm not going to go through the details. These are different details of taking out the proximal DVT by thrombectomy devices. What we need to understand is that DVT, once a DVT is there is a high risk of secondary DVT unless the entire clot is taken out. There is a very good study that if you have more than 10% residual clot, the subsequent DVT risk is very high. It also depends whether the patient has provoked or unprovoked DVT. Prognosis and recurrence in provoked DVT is much less as compared to unprovoked DVT. Now, there is an ESC consensus statement on extended management, and it is based on balancing risk factors of recurrence against bleeding risk, and it is preferred as the first-line anticoagulation therapy in non-cancer patients. So if you have DVT which is unprovoked, you should actually continue with long-term anticoagulation. In provoked DVT, especially the distal DVTs, the anticoagulation should be for 3 months. And in patients where you have unprovoked DVTs with high risk of thrombotic complications, like in cancer patients or in patients with genetic thrombophilia, these patients require lifelong management with anticoagulation therapy, which is usually NOACs or VKA. Now, there are some special conditions, especially during pregnancy. Low molecular weight is recommended for the initial or for the long-term treatment, while in cancer patients, we use it for prophylaxis as well. Now, this is one of our patients who had an acute DVT. You can see it on an angiogram, and what we used is did a pharmacoinvasive therapy. We did a popliteal stick, got a sheath in, took out the thrombus, did a pharmacoinvasive thrombolysis, and this is the final result which we got. And you can see these are the type of clots which are taken out. Now we use mechanical thrombectomy devices, and also we use aspiration thrombectomy devices like the penumbra or angiojet. This is our experience of 976 venous limbs in 911 patients in the last 7 years. The duration of DVT was 1 day to 2 weeks, and we did thrombolytic therapy alone in 286 patients, mechanical therapy in 637 limbs, mechanical thrombectomy and aspiration in 531 limbs, PTA alone in 143 limbs, and PTA with stent in 138 limbs. And what you can see here is that there was a complete resolution of this acute DVT in 638 limbs, and there was post-thrombotic complications only in 43 limbs. All the patients had oral anticoagulation therapy. Only one had pulmonary embolism, and the recurrence was only seen in 37 patients. Now, with this background of DVT and acute management and long-term management, let me shift gears to pulmonary embolism. We have already discussed the epidemiology. What is very important is there are risk factors, and the risk factors for DVT are the same as that for DVT leading to pulmonary embolism, which comprises of endothelial damage, hypercoagulability, and stasis. Once we have a patient of acute PE, we actually see whether the patient is in shock or not in shock. If the patient is in shock or hypotension, it is classified as high-risk PE. If there is no shock or hypotension, it is classified as low-risk PE. It's very clear that once you have a high suspicion of DVT leading to pulmonary embolism, you take these patients for CT angiography and bedside echocardiography. On the CT, we see thrombosis in the main pulmonary artery, branch arteries, and distal segmental arteries. And in the echo, what we see is we look for RV dysfunction, RV dilatation, and in the labs, we look for rise in NT-proBNP and also in cardiac enzymes, especially the troponin I. Once we establish the diagnosis of acute PE on the basis of clinical suspicion, lab test, echo test, and CT angio, and once we triage them into a low-risk and high-risk PE, low-risk PEs are treated uniformly by initial bolus of unfractionated heparin, 80 units per kg or 5,000 units, or low molecular weight heparins, followed by oral anticoagulation therapy, which could be vitamin A antagonist therapy or NOACs. While high-risk pulmonary embolisms are treated by, again, high doses of unfractionated heparin or thrombolytic therapy and or surgical pulmonary embolectomy, depending on the clinical condition of the patient. And all of this, according to the ESC consensus recommendation, have class 1 indication. thrombolysis, we can use either of the thrombolytic agents, streptokinase, urokinase, and RTPA. Streptokinase is not a clot fibrin selective agent, so that the dose is high and the results are inferior as compared to urokinase and RTPA. And the standard treatment is urokinase 4,400 units per kg as a loading dose over 10 minutes, followed by 4,400 units per kg per hour over 12 to 24 hours. If you're using TPA, we infuse 100 milligram over 2 hours or 0.6 milligram per kg over 15 minutes. Surgical embolectomy is reserved for patients who do not respond to conventional treatment and are in cardiogenic shock. Otherwise, if the better therapy would be a catheter-based pulmonary thrombectomy, which we are doing routinely and which should be done if the devices are available. There have been a prospective single-arm multicenter trial on ultrasound-facilitated catheter-directed low-dose fibrinolysis for acute massive and submassive pulmonary embolism. This was the Seattle 2 study, and it showed that the ultrasound-facilitated catheter-directed low-dose fibrinolysis decreased RV dilatation, reduced. There was 10% this study, and that's why we cannot go and take it universally, and there is always a choice whether we treat these patients in this way or by conventional thrombolytic therapies. We have a small study on percutaneous pulmonary thrombectomy and thrombolysis for B. This is our personal experience of 45 patients. And what we have done here is we have taken the patients in the cath lab, we have pulverized the thrombus with the help of a 035 guide wire, and we have taken out the thrombus by a thrombosuction catheter, and which is 9 French or 10 French in profile, and then we put in 2 multi-purpose catheters with multiple side holes and infused tissue plasminogen activator and complete the thrombolysis. Actually, this is a very rewarding procedure. We had a success as defined by 50% drop in the pulmonary artery pressure, significant improvement in SpO2, and 50% reduction in clot burden in 44 out of 45 patients. There is also a similar ESC consensus statement on the use of NOACs in anticoagulation or thrombectomy in acute pulmonary embolism, depending on the acute phase of the disease and the clinical presentation. It is seen that NOACs as an initial treatment in acute treatment of VT is beneficial and actually leads to a risk-benefit ratio in terms of treating these patients of acute VT and pulmonary embolism vis-a-vis their bleeding risk. Now, closed monitoring is recommended in patients with intermediate or high-risk PE, and the hemodynamic decompensation is a phenomena which may happen, and that is why these patients have to be treated with a team which comprises of interventional cardiologists, respiratory physicians, critical care physicians, and emergency physician. And with this combined approach, there has been a significant decrease in the death rate and also significant decrease in the comorbid complication and bleeding risk if we are using this mode of therapy in acute pulmonary embolisms which produce cardiogenic shock. So just to give you an overview, the initial treatment over the 5 days in VT is unfractionated heparin, low molecular weight heparin, or thrombolysis or vitamin K endogenous or NOACs. In intermediate treatment, we use vitamin K or NOACs as the first line of treatment for unprovoked PE for at least 3 to 6 months, while the use is extended if there is an unprovoked VT and the risk factors continue, or if the residual thrombus is present, or if the patients have cancer or genetic thrombophilia states. Hence, we continue anticoagulation for lifelong. And with this, I would end here, and I would be happy to take questions during the discussion. Thank you very much.
Yes.
So I agree. It's a very good presentation of Dr. N. Khanna, along with his personal experience in Delhi. That's very interesting and enlightening, because what we see in the real world practice is maybe different than the randomized trial. So this is the true data in the real world practice. Now, I open the session for discussion maybe at the end or whatever. A few
Yes,
comments.
at the end.
Yes, good idea. At the
I
end, we
will
shall.
suggest, yes,
Yes, good
at
idea.
the end. We will make it at the end. So we'll
Yes,
continue the flow of the.
good
Yes,
idea.
please. So Dr. Gupta, PK Gupta, sir, can you introduce Dr. Jain?
Yeah, sure.
Yes.
Right. After listening a very important topic of DVT and pulmonary embolism, let's move on to the another very important challenge which we have all faced during this pandemic. And initially, we all thought that the COVID is a disease of lungs, but later on, we proved wrong, and we realized that we are missing a lot of cardiac complications. So, deal with this very important and difficult topic. We have got our friend Dr. Ajit Jain, who is the chief cardiac surgeon at Rajiv Gandhi SS Hospital, Delhi. And I had a pleasure of meeting him twice or thrice during his Dubai visit. And today again, I would see him after a long gap. So he's going to talk on cardiac impact of COVID infection, unusual, unpredicted. Dr. Ajit Jain, floor for you.
Yeah. So just to add on that, he actually worked very hard. He did not come home from several months. He stayed in the hospital, and unfortunately, he also had to bear the brunt of losing our dear friend and his wife. So
Oh
that's a
my
tragic
God.
end of his whole journey. So now we hear from him.
Good evening, everybody. Today I'm going to present the cardiac impact of COVID-19 infection, unusual, unpredicted. When things started in 2019 and we started treating the patient in the early March 2020, since then we have traveled a long way and we have unfolded lot many mysteries. Now earlier lot many things were unusual and unpredicted. Now we can predict lot many things. This SARS-CoV-2, in contrast from the earlier coronavirus disease outbreaks in both its global and epidemiology and cardiac impact. In 2002, the SARS-CoV-2 pandemic arose in the Guangdong province, China, of the 8,098 people infected worldwide. 774 died, yielding a case fatality rate of 9.6%. In 2012, the MERS outbreak arose from the Arabian Peninsula and infected 2,562 people with a case fatality rate of 34.4%, and cases occasionally is still being reported. The current SARS-CoV-2 pandemic became evident in December 2019 from Wuhan, Hubei province, China. Overall, the worldwide apparent case fatality rate is estimated to be around 4%. However, the case fatality rates vary by country from zero point 0.1 to more than 20% and are influenced by the testing strategies that define the infected population, economics, healthcare resources, comorbidity rates, demographics, and politics. As in this diagram, I am trying to show you the very basic of SARS-CoV-2 viral entry and the life cycle. SARS-CoV-2 virus is having the 4 structural proteins: the spike protein, the membrane, the envelope protein, and the nucleocapsid. The spike protein is having the two subunits, S1 surface and S2 transmembrane unit. As you can see in this diagram, that this S1 surface unit is having N-terminal domain, receptor binding domain, and NRP1 binding domain. This S1 unites with the S2 transmembrane subunit at this junction where furin cleavage is there. This furin cleavage is the very important part of this spike protein because it decides the transmissibility, the rate of propagation of this disease. This furin cleavage was not there in SARS-CoV, that 2002 SARS-CoV-1. And this S2 transmembrane unit is having the furin peptide, the haptide retreat 1 and 2 and transmembrane domain. Here in furin peptide, it is having the TMP-RSS, transmembrane protease serenase. So these are the important part to make the entry into the host cell. This is the host cell where at surface, cell surface, this receptor binding domain is going to attach with the ACE receptor, ACE2 receptor. And these transmembrane proteases, serine and cathepsin and all other NRP1, these integrin, all receptors are there to make a portal of entry in myocardiocyte, in cardiomyocytes. Once it gets entry into the host cell through AC2 or TMPRSS2 or cathepsin, these virus, they are going to replicate itself. As following the cell entry in SARS-CoV-2, genomic RNA is translated into a large concatenated polypeptide corresponding to the ORF1A and ORF1B reading frames. These polypeptide contains the viral NSPS, non-structural proteins, that process the polypeptide chain into 15 to 16 NSP subunits. Most NSPS forms the viral replication and transcription complex responsible for the replicating the full-length viral genome. The structural protein, including spike, nucleocapsid, membrane, and the envelope proteins, are expressed from a subgenomic promoter in a series of nested transcripts and assembled with the full-length viral RNA in an endoplasmic reticulum and Golgi intermediate compartment. So, in comparison to SARS-CoV, the AC2 is having the higher affinity for SARS-CoV-2. The distribution of this AC2 receptor is at the heart, lungs, intestine, kidneys, testes, nose, and the mouth, while the nasal and pulmonary epithelial cells are recognized as the first infected cells. But this human ventricular myocardium contains all the requisite mediators of the SARS-CoV-2 binding the entry. So although TMPRSS2 is minimally expressed in the heart, there is a high expression of AC2 and other proteases which we are going to see in the diagram. Here you can see that AC2, TMPRSS, cathepsin B, cathepsin L, integrin ITGA5, integrin B1, furin, and NRP, all are distributed in all these tissues which are going to get infected. This color, violet color, is showing the heart, the left ventricle, where we are having all except this TMPRS is the minimum. Otherwise, we can see that coronary artery, tibial artery, the lung, the sigmoid column, the transverse column, small intestine, they are having all these receptors, and these are the organs which are going to get maximum affected by this SARS-CoV-2. Here in this diagram, we can see that AC2 receptors are the maximum at the pericytes and fibroblasts. Cardiomyocytes and vascular smooth muscle cell, they are also having the same. Vascular smooth muscle cell, macrophages and fibroblasts, they are having the cathepsin L and cathepsin B type of receptors. Here in this diagram, we can see that with the age, the number of AC2 receptors, they are decreases. That is the one reason of bad prognosis in the older age. In failure heart, if it is entering into molding, then AC2 receptor is going to be upregulated in this. So this upregulation in the failing heart or in the old age, it explains why there are more mortality in pre-existing cardiac diseases or in older age. So in the human heart, the generation of octapeptide angiotensin second from the angiotensin 1 is mostly 85 to 89% mediated by ACE. So in human ventricular myocardium, breakdown or hydrolysis of angiotensin second, which is formed by the help of ACE from angiotensin 1, is primarily mediated by the AC2. Thus AC2 nullifies the pathological hypertrophy and the other adverse effect of angiotensin second. In the following slides, we are going to see these all adverse effect of angiotensin second in case of if ACE2 receptors are downregulated. Here you can see this angiotensin 1 is going to convert into angiotensin 2 through this ACE. This angiotensin second is going to convert it into angiotensin 1 to 7 with the help of this AC2. If it is downregulated, then angiotensin is going to be much more and is going to give these all adverse effect. It is pro-inflammatory, oxidase, reductive stress, pro-fibrotic, pro-thrombotic, antifibrinolytic, cell proliferation, vasoconstriction, and sodium and water reabsorption. But in case of AC2 upregulation, it's going to convert into angiotensin 1 to 7 and is going to be anti-inflammatory, antioxidant, antifibrotic, anti-proliferation, anti-hypertrophic, anti-thrombotic, vasodilation, diuresis, and natriuresis. So given the cardiovascular protective function of AC2 carboxypeptidase activity under normal physiologic condition. So if we want to see the direct myocardial effect, the clinical evidence of these for acute myocardial injury among these hospitalized patients, that the evidence of acute cardiac compromise is common and includes acute heart failure, cardiogenic shock, myocardial ischemia or infarction, ventricular dysfunction, that's left ventricular dysfunction, right ventricular dysfunction, biventricular dysfunction, stress cardiomyopathy, arrhythmias, venous thrombolism. There are lot many series which they have predicted the percentage of cases as per given here. If we come to the pre-existing cardiovascular diseases like coronary heart disease, heart failure, or cerebrovascular diseases, or cardiovascular risk factors, male sex, older age, hypertension, diabetes, obesity, and other comorbidities, COPD, CKD, CLD, cancer, all these predisposes these patients with COVID-19 to more severe disease and mortality. As we have seen in that diagram, the different receptors which are present and the different organs of the body. So coming to the biomarkers evidence of the cardiac injury, we can see that prevalence of elevated of troponin, high sensitive troponin is 20 to 30%, and out of this 8 to 62% are showing the myocardial injury, and in survival group it is only 1 to 20%, while in all severely ill patients 46 to 100% of patients are having it. So this high troponin level is also associated with ARDS, mechanical ventilation, malignant arrhythmia, and deaths. Echocardiographic findings are also showing the right ventricular RV dysfunction in 26.3%, followed by LV valve motion abnormality, global LV dysfunction, grade 2nd or grade 3rd diastolic dysfunction, pericardial effusion. If we go for the CMR, cardiac magnetic resonance imaging, then we see the myocarditis is the most prevalent finding. 40.2% myopericarditis, tachocybul temporary stress cardiomyopathy, ischemia, dual ischemic and non-ischemic changes, RWMA, edema, late gadolinium enhancement in 85 out of 199 cases, 42.7, T1 imaging, T2 mapping. Additionally, there is perfusion mapping abnormalities were described in 85% of cases. Extracellular volume mapping abnormality in 52%, pericardial involvement including pericardial effusion 24%, and pericardial LGE in 22%. So post-recovery cardiac involvement, as you can see in this 100 cases series, that atypical chest pain is 17%, palpitation 20%, and dyspnea and exhaustion 36%. If we go for this series, that among 143 patients seen as the outpatient after COVID-19 infection, 12.6% were asymptomatic, and symptomatic were having the maximum fatigue. That's the commonest symptom. 53.1%, followed by dyspnea, joint pain, chest pain, worsen quality of life. Mechanism of direct cardiac injury was seen in the cardiac autopsies and the cardiac tropism of the SARS-CoV-2 was initially established by the quantitative RT-PCR detection of viral RNA in postmortem heart of the patient with COVID-19 and subsequently in endomyocardial biopsy of patient with suspected myocarditis. By electron microscopy detection, the virus-like particles within the cardiomyocyte, interstitial cell, and endothelial cell of postmortem hearts. So it has shown the RV dilatation in lymphocytic myocarditis, focal pericarditis, endocardial thrombosis, and small vein thrombosis. Single cell and the single nuclei RNA sequencing study have demonstrated expression of the AC2 in the pericyte, cardiomyocyte, and fibroblasts, with cardiomyocyte specific upregulation of AC2 in failing hearts. So the presence of the severe microvascular injury in the postmortem analysis supports a role for pericytes, which show the high AC2 expression in the single nuclei RNA sequencing study. So indirect myocardial effects, coming to this, indirect pathological mechanism includes the hypoxia, small bowel ischemia, acute RV failure. Cardiac injury may also stem from the dysfunctional immune response. I'm going to come on this in a bit detail of dysfunctional immune response, hypo and hyperimmune response, and systemic inflammatory response. So this is the normal immune mechanism of innate immune system, which creates the inflammation, which makes the adaptive immune responsibility a bit increased. So this cytokine release syndrome, which creates the hyperinflammation, which is being shown by the high IL-6 and TNF in plasma, shows the dysregulation of inflammatory or immune response, which is going to be followed by the adaptive immune dysfunction, which creates the lymphopenia. This was the only thing to decide that thrombotic episode is going on. That lymphopenia is predominantly reflects the T cell depletion where B cell numbers are preserved. And recent studies, they have suggested that the pre-existing protection against SARS-CoV-2 may be derived from the memory T cell immunity to common coronavirus. And these memory T cells activation can induce pro-thrombotic activation of the monocyte and contribute to thrombotic risk. Potential role of antibody-dependent enhancement, it has seen that in systemic immune dysfunction causes widespread endothelial injury even in tissue that are not directly infected by virus. So it is likely that the humoral factor may be eliciting vessel damage. So this vascular damage is going to be because of endothelitis. Platelet activation remains a common final step in the thrombus formation. Indirect activation of platelet and the interaction with the innate system is going to be there and is going to disrupt the subendothelial barrier, promote tissue factor release, activating the extrinsic coagulation cascade, culminating in the prothrombin to thrombin conversion and finally the thrombosis formation. Though this thrombotic arterial and venous occlusion are a major cause of the end organ damage, this is being shown by the high plasma D dimer and prothrombotic autoantibodies. So this is the total mechanism of direct and indirect myocardial injury. Now coming to the therapeutic part. So coming to this preventive therapy, these are the vaccine currently in the clinical trial comprised of the 5 different subclasses: inactivated RNA, DNA, non-replicating and recombinant protein subunit based vaccine. So therapeutic approaches directed at the AC inhibitor and other entry point, what we have seen the coronavirus life cycle, we are going to hit one by one. So these target-based drugs can be developed. Specific target spike protein AC2, TMP, RSS, CD147, integrin, adaptor-related protein complex, membrane lipid, viral replication, RNA-dependent RNA polymerase. Some novel therapies are there, reposition drugs are there, some treatment target viral proteins are there. So these interferon B, A1, A2, IL-6 receptor inhibitors, IL-1 receptors, these all are going to be there. So we are going to translate in all these knowledge in the strategy for the management of patient after COVID-19. So the ECG, electrocardiographic finding and the CMR, they are going to help us. The pathophysiologic membrane of the late inflammatory changes and the long-term impact of myocarditis or myocardial fibrosis, implication by the CMR on the heart failure or arrhythmic risk remain unclear. So longitudinal studies are needed to determine this natural history and clinical significance. So in post-COVID case, if we see a chest pain, dyspnea and palpitation, then we go for these investigation. And there are, beside concern over the CMR finding, cardiac injury, COVID-19 related, small fiber neuropathy and dysautonomia are now being reported in individual cases. posterior orthostatic tachycardia syndrome has also been identified. So despite abnormal CMRs, non-invasive testing, including serum biomarkers, ECG, and echocardiogram, may provide additional signs suggestive of COVID-19 mediated cardiac involvement. So uncertainty of the long-term consequences gaps are there. Future need. The potential for the long-term evolution, chronic myocardial disease, cardiomyopathy, and other cardiovascular complications, including heart failure, chronic sinus tachycardia, autonomic dysfunction, and arrhythmias. Evaluation of post-acute COVID-19 syndrome, long COVID-19, and recommendation for the long-term surveillance, monitoring, and return to exercise or sports participation remain area in need of further study. So concluding remark is the COVID-19 pandemic has produced devastating effect worldwide, loss of health, life, livelihood, particularly in undeserved and the vulnerable elderly, and those with prior cardiovascular disease. Further understanding of the basic viral host interaction mediating the varied response to the infection are yet needed to improve prevention and treatment strategy, including those for the long-term cardiovascular effect of the infection. Preventive vaccines offer hope that the pandemic may wane over this year, and their rapid successful development with the less than a year coupled with the increasing identification of the effective treatment are a testament to the massive commitment and tireless effort of the scientific community, frontline caregivers, and healthcare leadership. Lessons learned in our response to COVID-19 will hopefully prepare us for the future pandemics. Thank you. Thank you for patience listening.
And review as well as sharing your experience on COVID from beginning to the disastrous consequences, as well as not only during the COVID phase, post-COVID sequelae, now we are seeing in the form of cardiac involvement, as you have already mentioned. So with this, we will move on to the next lecture. Dr. Tamkeen, you can introduce the next speaker.
Yeah, thank you very much, Dr. Gupta. First, I would like to offer my condolences to Dr. Ajit for the irreparable loss. May Almighty rest his soul in peace. I would like to call upon Dr. Praveen Chandra, who is a dear friend, an excellent cardiologist, and a noble human being. He is the chairman of interventional cardiology at Medanta Medicity, Gurgaon, in India. He is recognized as one of the leaders in angioplasty in the country, and he is proficient in a lot of new devices and technologies. He has been awarded for success and achievement in the field of medicine with Padma Shri by the President of India. He'll be talking about development in non-surgical valvular treatment. And Dr. Praveen.
Good evening. It is a pleasure to participate in the SHAKEHEART meeting today. And today I'm going to talk to you about the new structural heart therapies in cardiology, the left atrial appendage and so on and so forth. So as you know that, we started interventional cardiology by treating the coronary arteries, and now we have moved from the coronaries, we went to renal arteries, then the other, peripheral arteries, and now we are working on the structures of the heart. And so that is the main, topic today, which I'm going to discuss. The mitral valve, the aortic valve, the tricuspid valve, the pulmonary valve, the paravalvular leak closures for post-surgical patients, and LA appendage closure. So this is the the entire mitral clip, and we do mitral valve replacement. We do mitral valve and valve therapies. Then we have for the aortic. Now the predominant therapy is a transcatheter aortic valve replacement, which is TAVR, and also aortic valve and valve implantations for post-surgical patients. Then tricuspid valve and valve, and also tric valve, which is a bicaval valve, which we implant in severe tricuspid regurgitation. For pulmonary valves, the pulmonary valve replacement is now possible, especially for the post-surgical patients. and paravalvular closures, again, both for mitral and aortic position for these patients. And for LA appendage, we can use either Watchman or amulet devices for closure of the LA appendage. Now let me see now elderly. The rheumatic heart disease patients also do come with aortic stenosis. Elderly patients beyond the age of 65 years who come with a severely stenosed valve. And if we don't treat them promptly, or if we don't start looking at their symptoms, these patients will have a very limited survival. And as you can see here, beyond the age of 65 years, mortality in aortic valve replacement becomes higher as the age advances. And many of these patients are actually left untreated because either they don't want to do the surgery or surgery cannot be done in these patients. So typically have a good anatomy and cannot be taken for surgery because of one reason or another, maybe COPD, maybe porcelain aorta, or for any reason is rejected by the surgery, transcatheter valve replacement. And this is definitely a multidisciplinary approach where a cardiac surgeon and a cardiologist come together and decide that this is the treatment of option. So mostly it is a transfemoral procedure. See that this is the type of valve, which is a self-expanding valve, which we are implanting in this patient who already had a pacemaker in the past and now is getting a valve replacement by doing a self-expanding valve, which is left into the position. And this is how we actually do the procedure. It is done in a cath lab and typically takes about 1 hour. Or valve is a balloon expandable valve, which these are the pictures. So once you see these kind of pictures on X-ray imaging, you can tell what kind of valve is there. And once we do these procedures, we measure the gradients, and usually the gradients are almost nil in most of the patients after the implantation. And then we check the coronary arteries also, if everything is okay or not. And 90% times there is no problem at all. And then we close the access site by doing this is a ProGlide which we implant. And most of our patients are octogenarians, septuagenarians, and sometimes even 90 years plus. So that is a very brief snapshot of what transcatheter aortic valve replacement is. Then the second is the mitral valve treatment. For this, I can tell you that it is for regurgitation. We use a very important treatment now because mitral regurgitation is a serious problem. And if you don't treat them, these patients will develop more mitral regurgitation and go into heart failure. So many times patients have multiple vessel disease and then they also have severe MR, and then MR is left alone, and then these patients don't do well. So surgical correction of MR does improve survival, and that is why we started treating these patients who have mitral regurgitation and cannot undergo surgery. So what do we do? So in these patients, if we just put them on medical therapy, that's not enough. So we have to have something which is slightly less invasive, but possible in these patients. Elderly patients, sick patients, post-bypass surgery patients, other thoracic surgery patients. And this, what we do is we put a small clip at the leaking valve. So this is a leaking valve, and we take this device which goes inside from the left atrium, and then we put this clip there, and so the regurgitation can be sealed. So this makes like a double orifice of the mitral valve by making a bridge so that the leakage does not happen in the mitral position. So this is very important, and this mitral clip procedure is now very common, and in many countries it is being done today for severe mitral regurgitation for any patients who have degenerative or functional mitral regurgitation. So who are those patients who can be done? So this is a way to identify, and this is echocardiographic parameters. And if on echocardiographic parameters these fit into these criteria, then generally it is okay to take these patients up. So not every patient can be treated based on the echocardiographic examination, and rest of the ejection fraction, etc. So these are the trials which have been done, and the latest is the QUAC trial, which established that this is a very effective therapy for treatment of severe mitral regurgitation in low ejection fraction patients also. And in this trial, it was compared with medicines versus MitraClip, and it showed that if you do MitraClip, then the cumulative hospitalization of these patients is much lesser. They don't need to go to hospital so many times, and the mitral regurgitation becomes much better, less than 1 grade in more than 80% of these patients. So the key results show that these patients do very well. Even the all-cause mortality also goes down when these patients undergo MitraClip plus medications. And the severity improvement is also significant. Severe MR trial showed very promising results. And this is how the procedure, this is, as you can see here, in an echocardiographic examination. Again, to do this procedure, we must have a multidisciplinary approach where a cardiac surgeon, interventional cardiologist, and echocardiographist is also very, very important to do this kind of procedure. So the patient selection and screening is important, as I told you already, based on the clinical profile and the echocardiographic parameters, we can make a decision. And this device has been approved for these patients who have high surgical risk and come with low ejection fraction and heart failure. So these are the various studies which have been done, and some are ongoing to see what can be done. So in our hospital in Vedanta, we have done a few of these MitraClips, and we have found very promising results in these patients. So the biggest challenge is, of course, the cost at this time, and the cost is quite exponential. The second therapy which we do for mitral is a valve implantation in a previously failed bioprosthetic valve, and this is a SAPIEN 3 valve which we use in these patients these days. The rest of the valves are in study right now, but a SAPIEN 3 valve can be used in these patients. So it is FDA approved for mitral bioprosthetic heart failure, and even in mitral annular ring failure, we can use this procedure and gives good results. Now, valve in valve, a lot of studies are available. Valve in ring studies are available, showing very promising results. So we can avoid a big surgical procedure for these patients who already have a surgery, and it can all be done through a small puncture into the femoral vein. So this is some of the patients where we have done these procedures, very sick patients, elderly patients, and who have very high STS score of in-hospital mortality. And of course, the Euro score has been high in these patients. We were able to do it based on the parameters of which kind of valve it is and what is the size of the valve. So we measure the size of the valve like this, as you can see here on a CT scan, and then once all identification of size and make has been done, we choose the valve from a trial. These are some of the equipments which we have sometimes in the cath lab when we are doing valvular heart procedures of some complexities. So it is done in the general anesthesia, transesophageal echo, and you can see this is a patient where a surgery is already been done before. He had implantation valve in valve for a. So we cross the valve with a wire, balloon the septum, and then go ahead and implant the valve. So you can see the valve is being positioned across the first valve, and we get a very good result. And once we are done, we even close the hole which we make in the septum by a device. So this is the post-mitral valve implant echo. You can see that there is no MR in this patient, and the valve is functioning now normally with no leak at all from the side also. And these are the kind of patients we typically do for mitral valve and valve implantation. So MitraClip is for severe functional and degenerative MR, and TMVR, which is transcatheter mitral valve replacement, is for bioprosthetic valve dysfunction. Now, then the tricuspid valve is also now treatable, and this is a bicable valve which we have started doing now for the last 3 years, and we have shown good results especially in those patients where there is no other option. The patient has severe TR, not responding to medical therapy. And this is a typical patient. You will see that the TR has increased a lot over many years. So we replaced the valve by putting two, one in the SVC and the second is in the IVC. So this is a two bicable valve, which we do in patients with severe tricuspid regurgitation. So this is the data which is now available, and now we have our own experience showing that it works. Now the PVL closure is another procedure which we do in structural heart treatment. It is in those patients where surgery has already been done and the valve is leaking from the side, where we do the PVL closure, both on the basis of the size of the leakage and of course the location of the leakage. So in this patient, we did a paravalvular leak closure first, and then we did a bicable valve implantation, as you will see here, and we got a very good result. So based on these, all these new diagnostic modalities and echocardiography, we are able to do all the treatment for paravalvular leak, for severe mitral regurgitation, for severe aortic stenosis, and we get very good results in structural heart treatment from interventions. Mostly these patients get discharged in 2 days' time. Thank you very much.
Is Dr. Chandra available? Doesn't seem to be. Dr. Ajit, you can unmute. Dr. Ajit, please unmute. Dr. Rajiv, please unmute.
Dr. Tamkeen also.
Unmute, please.
Mute. Yeah.
So we can start the discussion. Yeah. So let's start with the presentation one on BTEP. Dr. Rajiv Gupta was going to give some comments.
Yeah.
Dr. Rajiv, please unmute. Please unmute yourself.
Anyway, Dr. Khanna is around,
Yes.
or?
No, he is not. He excused.
He excused. Okay.
So let's start a discussion. Yes.
Yeah,
Dr.
I think if Dr. Khanna is not there, we can start on the second topic.
Yes. Dr. Ajit is here.
Yeah, Dr. Ajit is here. So, any case which really baffled you, Dr. Ajit, in the beginning, when you were not aware about the cardiac involvement, retrospectively you analyzed?
Initially, when we started dealing with the COVID, we
Right.
were treating it as a respiratory disease by and large. But gradually, when we have realized that most of the patient at the time of the first wave, they were just requiring the oxygen, that's it. And a very few patients, they required ventilation. But BiPAP requirement was much more than the ventilation, mechanical ventilation. But the mortality, when we have seen, it was because of the cardiac problem, the sudden death. When we have started echocardiography, we started seeing the RV dysfunction, we started seeing biventricular dysfunction, and in our ICUs, we have started noticing the arrhythmia part 2. So we concluded that most of the death at that time, we thought it is because of the cardiac reason, not because of the pulmonary reason. And when we started analyzing and when we started going through the different studies, then we have found that nearly 9 to 10% patients were reported in the first series for myocarditis, and around 9 to 10%, 11% patients were reported for the MI cases. And arrhythmias were reported in different series from 15, 16 to 22%. So when we saw that the mortality in the COVID it is more because of the cardiac reason rather than the pulmonary reason. Then we have
Absolutely
shifted
true.
our whole orientation towards that, and we started doing the troponin T to all the patients, troponin I then with anti-pro BNP, and we have make it a standard that we are going to do anti-pro BNP, D-dimer, and troponin high sensitivity I to all the patients who are landing into the ICU. And gradually we have realized that almost all severe patients, when we were categorized them mild, moderate, and severe, the COVID disease, most of the patients who were having the severe disease, they were having the high troponin I level, and their D-dimer levels and anti-pro-BNPs were also high. So
High.
our whole treatment shifted to
Thinking was changed. Yeah.
cardiac orientation, and we started involving our cardiologists into that.
Yeah, in fact, during the first wave, two of my doctor's colleague, one was ENT surgeon and another was physician. Both had arrhythmias, and initially we did not have any clue. He was a diabetic hypertensive, so I thought he is already predisposed for atrial fibrillation. So he has developed, but practically it was induced by COVID.
Yes.
So later on, we started realizing what we missed in the first wave was all due to the cardiac involvement instead of giving other explanations. And then we started taking active interest and we get recognized that even now, those who have recovered after a year are still lingering on with the symptoms, and some have got still persistent LV dysfunction, some form of cardiomyopathy, some form of arrhythmia. So, all these things are still lingering. And some of you might have gone, I think 2 days back, ACCAHA released post COVID sequelae algorithm and the concepts. So, they have described it in all great details how to go around.
True.
And in
So
our
to add to the story, we have seen several cases of myocarditis after the Pfizer vaccine. That is also we
Yeah,
have
yeah,
seen
yeah.
here very
Yeah,
clearly.
that we have not seen because we don't have Pfizer here.
Yeah, we
Yeah,
have seen here,
right,
and
right.
it's not just one, but there are more actually. So
Okay,
I won't say a very high percentage of patient, but really at least we know 4 or 5 patients in front of our eyes. So I will say it is a
right.
lot.
Okay.
Yeah.
and even with few,
Dr. Rajiv, yeah. Have you seen
like
Dr. Rajiv?
Yes, I agree with your what Dr. P.K. Gupta. I endorse his viewpoint regarding myocarditis. It is reported, well reported complication, no doubt about it, with both the mRNA-based technique involved. The vaccines, of course, more with the Moderna than with this thing. Now the thing is with myocarditis, good part is this: the prognosis is always good. And initially, they write no mortality has been reported. Later on, I think they reported some one or two mortalities with that also.
Mortality,
That
yeah.
is a very comforting news that even it happens, it recovers. Now, issue is how do you confirm the diagnosis of the myocarditis, because LV dysfunction could be a lingering phenomenon of long COVID, and unless we do cardiac MRI, which we don't do in our clinical practice, it's very
Yeah.
hard to say it is a myocarditis induced with the vaccine.
No,
Of
to
course,
establish the diagnosis of myocarditis, you have to do a CMR, oblique endomyocardial biopsy. These two things are required.
yes, when you publish a case, that's true.
Yeah.
Usually, myocarditis is seen after the second dose, not usually, almost invariably, not after the first dose.
Yeah.
But we have seen during COVID leading to myocarditis, we have seen quite frequently.
That's true. That's true. I agree with what the speaker spoke,
Yes,
Dr.
yes.
Ajit,
Yeah, yeah.
and entirely agree. Initially, we were befooled, but later on realized it is a more of a vascular disease. That's true.
Right, right.
Yes.
Dr. Ajit, any your experience? How long you used anticoagulants? Those who experienced thrombotic phenomena, either DVT, PE, or anything else? How long you continued the anticoagulants in them?
Like after discharge for a month, for 30 days, we were putting them on NOACs.
Yeah, 6 weeks
When
I continued. Any data beyond that?
Actually, we have used NOACs up to that only, and we kept them on a low dose aspirin and statin too.
Yeah.
That's a very working situation.
Dr.
You
Gupta,
see, in
any idea about the statins and RAS blockers?
you are right. There are thoughts which are going on. People have compiled the data. Initially, when we started the first wave following, there was a serious concern of AC inhibitor blockers and ARB blockers. In fact, I also thought of calling my patient and discontinue their therapy. Initially, they were put on. Later on, when the report coming, it is rather favorable. And in fact,
That's
I
right.
happened to write a letter to the editor to Clinical Cardiology where they were happy to publish about it. So what happens when the virus enters the cell? It knocks down your AC2 receptors. AC2 receptors, it enters through it, and then after entering the cell, it knocks down the receptors completely. Now, this depression of the or suppression of AC2 inhibitor is linked with the severity of the disease. But if the patient is already blocked AC receptors, it's failed to knock down the AC2 receptors completely after entering the cell, the virus. And therefore, that is one of the theoretical explanation as one of the protective mechanisms. Statins are protective, I think so very much, because it's a
Because of
vascular
their
disease.
immunomodulatory effect, there is some data.
Immunomodulatory, very important, very important. And therefore, it is advisable not to start a statin, but to continue if the patient is on
Yes, if
ARB
they
and
are
other
on.
things to
That's right.
statin without any fear. And that goes, thing. And there is no significant drug-drug interaction, also drugs used for the COVID also. That said, just a point I want to ponder, because I was editing one of the articles. Now, the guidelines initially we thought, of course, in severe COVID patient admitted to ICU, systemic anticoagulation is a must. But now the things have shown to be counterproductive. So, just a prophylactic dose of anticoagulation, the severe cases admitted in the ICU is all. That's what the data is emerging now. The papers are coming up very fast, and now the guidelines of the anticoagulation needs to be redefined.
In fact, a trial with ramipril is already on. It's going to be published soon.
No wonder, no wonder. The other thing is regarding the first Dr. Khanna's talk. Pulmonary embolism, even I have committed fatal mistake. Truly speaking, over my careers, I recall patient I missed and he died. I recall a Caucasian lady in which a small pulmonary infarct, and then it came into morbidity meeting, and we have to explain it. So, particularly this Caucasian race, there's a greater racial, this thing is very highly susceptible for the embolic, both DVT and the pulmonary, and we have to keep a very high index of suspicion because we practice in UAE, all kinds of people we deal, all races. So this is something, a catch point in clinical practice in the particularly UAE, though deal with Caucasians people.
Yeah, that's true.
True. It is a disease of high suspicion. One should always suspect and respect
That's right.
as soon as possible, because the time frame is very limited. So as you said, we recall one patient in Apollo Hospital. He was a doctor shifted from some other hospital. He was very, very nice, stable person. Only was little breathing difficulty, and in 10 minutes we saw him losing his life. And by the time we got results, D-dimer, etc., it was confirmed it was most likely pulmonary embolism. It is a it's a
I
very
still remember when I was in Iraq, there was a Filipino lady, 39 years, not quite young, 39 years. She was admitted as a non-ST elevation MI, troponin positive, ECG changes, T-wave inversions. When I went next day for the rounds and I took the history and examined, then it was suggestive of more of PE and then non-ST elevation MI. I did the bedside echo, severe TR, RV dysfunction, and pulmonary artery pressure 69.
No wonder.
Although there was no thrombus in RV, RA, or pulmonary artery, And then she was put on full anticoagulation, and then subsequently she improved and settled. But this does happen in clinical practice.
It doesn't. My colleague encountered a lady, middle-aged, not middle-aged, in 30s, white lady who came with shoulder pain, and he came to the internist, and then there was no evidence of hypoxia and the triage and other things, and of course he also did ECG. It was normal, but ultimately after 2 days we realized she has pulmonary embolism.
Yeah.
Like
Yeah, so
one of my colleague, cardiologist colleague, Dr. Gaurav, his elder brother, he was with us in our ICU after COVID in severe disease. And we have noticed the same, that RV dysfunction and dilated RV. And we were having the very high suspicion the way his saturation dropped. And finally, after concluding all the findings, we have done the thrombolysis. And surprisingly, in next 1 hour or 1 to half an hour, his saturation, which was around 40-50, fallen down to 40-50%, again went to around 80-85%. So only one case we have done the thrombolysis for pulmonary embolism, and we got the positive result.
So no,
Even I
it's a
agree.
disease which is very rewarding as well.
That's right.
A
That's
rewarding
right.
treatment, and then the very quick and fast development on either side. So my question is that at least for rivaroxaban, it is recommended that it can be started from day one. You don't need to give a low molecular weight heparin. And I have done it in my practice. Anybody else does it? Because it's still we are in a mode of giving
No,
5 days
no. I have used a lot rivaroxaban as well as apixaban from
from
day
day
one.
one. This is what.
Day one. We have
Yes,
not used a low molecular weight heparin at all.
yes, that's true.
That's also my experience.
Yeah.
Yes, good. Well,
But not
so
in patient those who come in shock or severe
no,
high
no,
risk.
that's a different
That's
category.
a different story. That's a different
That's a
story.
different story. Yeah.
Yeah.
Right.
Low and intermediate
Yes.
risk.
Yes. Dr. Tamkin, anything from your side before
Yeah,
we conclude?
I just have a question regarding the anticoagulation in the patients who have, as Dr. Gupta said, that they have documented clots, they have documented high D-dimers with clots and symptomatic. But why we need only a prophylactic dose of anticoagulation? Why not a full dose of anticoagulation when they have, you know, the
In the
clots?
ICU setup,
Or
patient those who are
no, no, or elsewhere as well. I mean, not ICU. They have DVT. They have a documented DVT.
yes.
Why? Yes. So
Then
why?
once
Full
you are right. Once
anticoagulation.
you have the DVT documented, other thing, no doubt it goes for the
Well, I mean, this
full-fledged
I
anticoagulation.
heard that
I am
Dr.
talking.
Jana said that you give a low dose of this anticoagulation with aspirin.
No, that is not the proven DVT. That is, I think he meant by high D-dimer and high suspicion of thrombosis after COVID, not in a proven DVT. Proven DVT treatment
Proven
guideline then
DVT, full
changes.
anticoagulation from day one.
Full anticoagulation. Yes, that's
Yeah.
true.
The
No doubt
moment you
about it.
detect it, whether silent or symptomatic.
That's right.
And I have one
Okay.
more small question. This because everybody faced the brunt of COVID-19, and I was also in the front line. A lot of people used to come at night, young people, 25, 28, with mildly raised troponin in the normal EKGs and no significant risk factors for heart disease. And we used to give them aspirin and then evaluate further for coronary artery disease later on when they were discharged. So how it's in your practice? I mean, what were you doing for the patients who are presenting with similar, biochemical derangement?
Yeah, most likely all these patients are of myocarditis until unless you do the angio and you say there is some obstructive coronary artery disease. Otherwise, most likely majority of these patients were of myocarditis until unless you have got an explanation of a non-cardiac rise of troponin.
Troponin. Yeah, that's true. It's a kind of inflammatory marker as well.
That's right.
So that's
And
fine.
how
So
you
let us conclude, Dr. Gupta.
Pardon, sir?
Let's conclude for the day. Shall we
Yes.
conclude for the day?
Yeah, sure.
I think you will be better judge for to conclude, you know.
Yeah. So yeah, I would. We always believe in timely finish. So
Yeah,
we are
sure.
well in time, and so any of the moderators will take the charge and conclude this session, please.
Yeah, so we had a wonderful session, and it started with Dr. Khanna dealing with a very important topic of VTE, and then we moved on to the burning topic of COVID, and Dr. Ajit has given a wonderful disposition of the whole COVID cardiac complications and sequelae. And then we have got the real world interventional cardiology, structural interventions, including mitral valve clip, as well as mitral valve replacement.
Mitral, split pulmonary, yeah, all kinds of
And
interventions. Yeah.
TAVR, and then paravalvular leaks. So overall, we have a wonderful series of lectures, as well as we have a wonderful discussion amongst all of us. We enjoyed a lot, and I have been benefited a lot. And the most important thing, I have seen Dr. Gupta, Dr. Ajit, and Dr. Tamkeen after a long gap. Of course, Brajesh, I keep on talking and saying, but it was a real pleasure to see all of you, and thank you very much.
Thank you. So thank you all the moderators and faculty members, colleagues taking time out from your busy schedule and contributing to this scientific activity. This has been a wonderful day all through. 5 hours and 11 minutes we have done, as there is a clock here which shows clearly. So we have been live for 5 hours and 11 minutes. We conclude this evening, and tomorrow we will be having the hybrid session. Many of us in the local region will have a privilege to see each other in person. So Dr. Rajiv Gupta, please come over. You are in UAE. Dr. Tamkeen, without doubt, you will join us. And we request all the audience to please make it on time tomorrow morning if you're coming in person, so that we don't delay, because the sessions are, you go through the agenda, you will realize the sessions are prolific, wonderful, very power packed. Especially the first session is actually crammed. I'm really already worried that will I be able to finish in time. I have kind of obsession of doing the things at the right time. So I start at time, try to finish at time. So, so forgive me for my obsession, which is always there. So
Brajesh,
I'm
I
already
really
worried that how will I
appreciate your
manage.
passion and enthusiasm since beginning, and it is still going on.
Thank you. Thank you so much. It is all because of every one of you who have supported me, who have encouraged me, who have taken part in it. I cannot present 11, 13 hours myself alone. It is a group of people who are supporting me. So thank you so very much. And hopefully next year we will all have in person. Everybody should be able to come down from wherever. So thank you. Good night,
Okay,
everybody, all
thank you.
colleagues,
Good night.
all
Bye.
audience.
Thank you. Good night.
Goodbye. Thank you.
Bye.
Thank you.
Bye.